Morning, everyone. I welcome you all. You have taken your time out on a Sunday morning to join this program. OphthaEva it gives a platform for young female ophthalmologists to present their academic work, but definitely we don't believe in any gender bias, so everybody is welcome here. And I would also like to welcome Dr. Chaitra Jaidev and Dr. Muna Bhende, who joined us in this fine morning. And without further ado, let's start with the program. I would like to request Dr. Swati Agrawal to please moderate the first session, which is cataract with retinal problems. Dr. Swati.
Morning all. It's very pleasing to see everyone on a warm, rainy Sunday morning. And we have Dr. Muna Bhende with us online over the Zoom platform. And welcome to all. I would like to invite our chairperson, none other than Dr. Abhijit Ghosh, on the podium, sir. We look forward to gaining insights from you. And he just landed yesterday from UK and he obliged to come here and be a part of this program to inspire us. So I thought it was for us. Oh, I know you're teasing us anyway. So, and we have our keynote speaker, Dr. Chaitra, with us. And she's come all the way from Bangalore. But let me start the session because without much ado, I'll just start the session. And the first topic is by myself, cataract and diabetic retinopathy. Worldwide, more than 2.5 million people are affected by diabetes mellitus. And India is the diabetic capital of the world. Diabetic patients are 2 to 5 times more likely to develop a cataract at an earlier age. All the pathophysiological changes, including the polyol pathway and so on. So the diabetic patients there can be a diabetic cataract or it can be combined with a senile cataract. But what other than these two do we see in diabetic cataract? Well, we see patients coming with injections given, or so these patients are now coming with a posterior molar also. And we have to be sure that there can be a posterior capsular dehiscence. So why is cataract surgery different in a patient with diabetes? Well, it leads to relatively rapid progression of diabetic retinopathy. Uneventful cataract surgery results in increased inflammatory cytokines in the eye as early as day 1 post-op, and it takes 1 month to decline to preoperative levels. So this reduces retinal thickening and so on, can even lead to rapid decrease or loss of vision. And if this is the scenario with uneventful cataract surgery, I can't imagine the situation with eventful ones. Well, so we should go for earlier cataract surgery before the lens opacity is obscure, the adequate macular assessment and other fine recognition. So I would be dividing the topic into preoperative considerations, the intraoperative and the postoperative. So as regards to the preoperative consultation, the preoperative counseling the patient is very important. We need to tell them that they need to get themselves monitored in the postoperative period and that the glycemic control should be good. So again, beware that patients might trick you. They might just give the blood of their sister and come up with a well-controlled blood sugar. It happened with me. So, and in the post-op period, it might run into trouble. So preoperative workup, look for iris neovascularizations. OCT should be done in all the cases. You can also go ahead with fluorescein angiography scan as required. Come on, when to do PRP? But if there is a significant lens opacity which precludes the operative PRP, then it can be done immediately following the cataract procedure or within a week, or it can be combined with cataract. PRP. In cases of untreated or previously treated macular edema. And we should actually try to keep the retinopathy and maculopathy under control for this was the right eye OCT here, and we have the left eye OCT. Left eye, you can see few distinct things. Right eye is not having any such issues, any diabetic changes, major diabetic changes. So I went ahead with flaxseed toric in the right eye, and in the left eye, I went ahead with simple ranibizumab injection. So right eye, after flaxseed toric, I landed up with a macular edema, and in the left eye, it was fine. So lessons learned is if the other eye is having diabetic retinopathy changes, we should consider giving intravitreal anti-VEGF intraoperatively. Now, cataract surgery increases the risk of progression or redevelopment of macular edema to 20 to 50%, and ongoing treatment is important. No intraoperative injections have been given, and for persistent or refractive diabetic macular edema cases, steroids can be given. Okay, what are the intraoperative considerations? Well, we go for vasoconstriction because it leads to less inflammation earlier and better wound healing. A larger capsular access site should be used because then we can have a larger IOL uptake, and these patients are prone to more of capsular phimosis in the postoperative period. Again, that becomes an issue in treating the peripheral retinal pathologies postoperatively. Diabetics, we should be doing again anti-posterior capsular polishing. So this also aids in better visualization of the peripheral fundus later. The timing of the surgery, so we shouldn't be rushing through the surgery. It is not to be uncomplicated, but it shouldn't be very long or delayed either. And anticipate pre-existing PCR in patients who have received intravitreal anti-VEGF injections in the pre-op period. So the pupillary dilation might not be very good, so consider iris expanders in those cases that there could be intraoperative hypema or keratoendotheliopathy or endothelial cell loss is greater in diabetic patients. And at the end of the surgery, again consider. What about intraocular lens choices? We should go for larger diameter intraocular lenses. And these lenses should be hydrophobic acrylic lenses with angle of flow is less. And again, if the patient needs to go for the silicone injection, oil is used during the retina surgery later on, then there's a adhesion of chance of adhesion with other kind of lenses. So acrylic lenses are preferred. With multifocal lenses are a strict no in patients who have a poor glycemic control, and again avoid iris flaw lenses because is not proper for posterior segment evaluation, and destroyed macular edema is higher incidence. So combined cataract surgery in vitrectomy can be done in cases of non-clearing vitreous hemorrhage, macular TRD, persistent diabetic macular edema. Iron peeling is shown to be beneficial in case of persistent DME because we are interface is a contributing factor in the development of this. And but some cases are less suitable in cases of severe traction or so. So post-op consideration, we should emphasize on a regular checkup post-operatively because the risk of treatment requiring DME increases sharply in the post-op period. And those with moderate to severe MPD are at most risk. Also be knowing that like how to differentiate between diabetic macular edema and pseudophakic destroyed macular edema. With this thing, I would like to thank you all. Thank you.
Number two is you have to explain, especially in proliferative retinopathies in young persons, there is deterioration as increase of retinopathy after surgery. This is one very, very important thing. We have seen a lot of cases. I don't know, Oja and Poda, everyone will agree or not. There have been deterioration of cases, so you'll end up in trouble. So these are the very two pertinent points which I wanted to share with you. If anyone has anything else to speak, please. Yes, Chaitra.
Have different challenges once multifocal lenses are used. So what is the take? I mean, are people more and more avoiding it or going for it? Because I think the patient demands it.
It's possibly not the question avoiding. You need to do the surgery many times.
I'm asking for the lens, the choice of lens.
See, a patient with maculopathy or evident diabetic retinopathy definitely I would, because of the lens as such and plus lowering of the contrast sensitivity in these patients, definitely because by putting a multifocal, I know I am reducing the contrast sensitivity by 30% average, whether it's distance interval. So evident retinopathy, definitely. But a retinopathy who is under, as she has said, glycemic control. I mean, the patient is diabetic for last, say, 15 years, 10 years, good glycemic control. I don't see anything. Patient is maybe in his 60s or something. Young diabetics, again, is very, because they would come and ask, not the, but there, I mean, they're explaining the risk, as you said, counseling. You can, if you can have surgery or if you want trifocals or bifocals, definitely you should have to, or you can counsel, but I rarely do window.
Motivate. Actually, your role possibly as a cataract surgeon in diabetes is to help the retinal surgeon for further treatment. That is the most important takeaway message, which I feel. You should be helping. You should not be seeing in your context of a cataract surgeon. You should be seeing in the context of the patient and the vitreous and the surgeon, retinal surgeon, for doing things later.
Yeah, the other way around, like as for the patient's perspective, if the patient has flooded diabetic retinopathy or a previous history of treated macular edema, they have very high chances of recurrence of macular edema.
Absolutely.
So, patient don't get benefited out of the lens. So that is what we need to tell them, even if they ask for a multifocal. So in case they do not have any, they are diabetics, but they don't have diabetic retinopathy. So even then, they have a small chance of developing diabetic. 1%, like Usha Chakravarti et al. Had published that even if they don't have diabetic macular edema preoperatively, they have 1% chance of getting DME after cataract surgery. So we need to tell them very clearly that you may not be benefited out of this multifocal lens if you have recurrences. So that is something a patient should be clear about. And
Why do you want to give multifocal lens at all? That is my
if
question.
patient wants, like now they
It
are
is not the
demanding.
question. That
Exactly.
is the way counseling comes.
Exactly. That's what I
Counseling,
said. You have to clearly say in counseling that you won't get the benefit. So don't opt for multifocals. Exactly.
For the trifocals, the current trifocals with this, do you have problems in operating retinal surgery? Lasers.
Yes.
Other,
You have multiple rings, 15, 20, 25. So every laser is just.
And I think more importantly, say PRP, we don't do more than twice or thrice. I think this 30% reduction that you're speaking about in a young diabetic who's eventually going to develop diabetic retinopathy and macular edema, I think that is something that a patient will be more acceptable to understand than saying your treatment may be compromised. Because the minute you tell them, eventually your vision might be compromised, your central vision, reading vision, I think they're going to be more amenable to understanding why they should not be going for a premium IOL. Because that push is there now for premium IOLs. I'm not telling you surgeon point of view. I have very young diabetics who come and have an early cataract because of their disease and don't want to wear spectacles. So I think that's a big situation we have.
laser is very difficult. Laser is very difficult.
the other point, Dr. Shati mentioned about giving injection in a patient who has no edema in the operating eye, but edema in the other eye. I think is a bit controversial, but
No, I wouldn't do that. So what we're doing now for all patients is as part of the cataract package, we are screening all of them for OCT because subtle edemas we miss. But then once you've documented a subtle edema, you can tell them that this can become worse. And if the systemic control is not good, you can develop new edema also. But we already have an OCT documentation of an edema which you could have missed either because of an urgent examination, a hurried OPD, or a media haze. But the OCT more or less picks up even the smallest of edemas, and God forbid it's in the foveal area. You're going to obviously compromise a patient who's expecting to see six first post-op. That kind of pressure we retina people don't have. But all the cataract people have that pressure of performing so well that you need six so the patients who come to us first day post-op from the cataract department are people who have the macular. They check their vision. We never check for few weeks. But cataract people want to know how well they've done. First post-op day, vision is even 6 times parts retina opinion. And then we run the scan, it's something or the other, or clinically, or inflammation.
Your center, how if you see her like she showed and the patient within say 7 days earlier way, how soon do you inject? Do you inject?
3 days. Within 3 days we inject.
timing of cataract surgery, you suggest combined cataract with intravitreal injection or suggest in between two injections?
So it depends on the degree of edema. So if it's a very severe edema, I prefer to inject at least a week or so before. Second is if there's any pre-existing inflammation, I do not inject together because then there's a blame game. It became worse because of the injection, it became worse because of the cataract you don't know. And you can't explain to the patient. If it's a very subtle edema and systemic control is not great, I'm expecting it to become worse, during cataract is okay.
The ideal would be drying up the macula and then
Yes.
go ahead because it's a non-emergency.
Yes, because what then happens is that you know that the vision gain was because of the injection. So many times patients with some cataract and edema, the minute you give the injection, they say, my vision is clearer now. I don't even need the cataract immediately.
those people who do cataract surgery and all. So what is the preferred choice? Like which cases you choose to give anti-VEGF injections intraoperatively and which cases tricot triamcinolone methylprednisolone?
So if I see a lot of hard X-rays, a very severe edema, a lot of subretinal fluid, 700, 800 plus, I prefer to give an Ozurdex. Simply because I know that for the next 2 to 3 months that the patient's vision is going to be, because you're expecting some post-op inflammation anyway, and it's already a largely inflammation-based edema there. But if it's a very mild edema, anti-VEGF works fine. So it depends on the type of edema. Then again, the systemic issues of the patient, any known cardiac issues, you anyways can't give anti-VEGF. So it's an overall thing. And we do also give simultaneously Ozurdex intraoperatively. We do that during that time.
So those were extensive tips from our esteemed panelists, very knowledgeable panelists, Dr. Chaitra Jaydev, Dr. Ajay Paul, Dr. Siddharth Ghosh, and Dr. Shubhatopal. I welcome you once again and all the audience who taken out time on this Sunday morning. With this note, I welcome the next speaker, Dr. Devjani Mukhopadhyay, for her talk on cataract and macular diseases. Well, Dr. Devjani, she has done her fellowship in lasers in diabetic retinopathy from Arvind, and she's also been trained at various other high hospitals and currently working as a senior consultant ophthalmologist at Eastern Railways, Kolkata. Over to you, Dee.
Thank you, Dr. Swati, for your kind words. A very good morning to you all, respected chairperson, sir, panelists, my seniors, and friends. At the outset, I must thank Dr. Sangeeta and Dr. Swati for inviting me in this session. Today, my topic of discussion is cataract and macular diseases. Though most of the parts of my presentation has already been discussed in the session. eye study and Blue Mountain eye study has shown there is an association between cataract surgery and development of AMD 5 years after the surgery, even in the patients with no AMD at the baseline. As rightly stated by Dr. Cooperman, that even if the visual loss is 30% due to cataract and 70% due to macular degeneration, he still suggests that patient will be benefited by cataract surgery because there is a low risk of progression of AMD, and patients should be counseled that though they may not gain letters more, but there will definitely be qualitative improvement like seeing better, clearer colors and brighter light. If there is a history of venous occlusion, systemic evaluation like cardiac issues and hypertension, diabetes should be taken care of, along with checking for neovascularization in the retina and anterior segment. And before cataract surgery is contemplated, macular edema should be taken under control. In eyes with prior vitrectomy, the time of development of cataract is very important, because if the patient regained good vision after vitrectomy, we can be reassured about the retinal potential. Whereas immediately development of cataract following surgery, though rarely, but there is a chance of injury to the posterior capsule. Following pars-plana vitrectomy, there may be the injury to the zonules, and so we should keep in mind there is a possibility of IOL decentration. It can happen later on also, and the trampling effect of the bag in absence of solid vitreous. So we should keep these CTR, Cioni, and capsular hooks in hand. So the patients with coexistent condition should be made clearly understood that that's what is different in their eyes, and they may need further surgery. Preferably, family person should be present during patient counseling, because patient may not remember every word that is told preoperatively to them, and this should be recorded clearly in the note that has been discussed with the patient. IOL consideration already discussed, that they may wonder why they are advised monofocal lenses with they have to wear glasses, and want to know about that multifocals or extended depth of focus lenses, as their Google doctor has explained that they will gain clarity of the vision after surgery, but we don't want to lose them more contrast sensitivity in an already compromised eye. Topical NSAIDs should be continued for some time in cases with macular diseases, even if the macula is treated. So finally, the take-home message, a thorough preoperative evaluation to exclude surprises intraoperatively and immediate postoperative period. We should plan ahead for the foreseeable complications rather than stressing out oneself in the OT. And though the patient expectation is very high, we have to accept and tell the patients that sometimes we cannot do what they are requesting for their own benefit. Thank you very much for your patient hearing.
Thank you, Devjani. But there is one question to be asked. How do you deal with your cases having macular problems and cataract? These are all theoretical stuff. But what do you do? What do you do, and what is your idea of treating patients like this?
So, though OPD may be very busy, we take a couple of minutes more for counseling of these patients. Particularly, as I've already told, that patient party or family member must be called on into the room for counseling, and they must be made clear that showing the OCT is a good example, that this is the problem in your eyes, and properly explaining them the prognosis, that a disease may recur, the disease may progress, and you may need second surgery.
Okay. In many cases, IOL acts as a low visual aid also. In certain cases, it's very important for you to know.
Yeah.
Especially in AMD is dry, they act as a low visual aid also. This is very important. I want to ask Ajoy ma'am, and everyone, Siddhartha and Shogatupal and everyone, please interact. This is a very important subject.
No,
which
as she has said, I mean, counseling. So OCT has become, I mean, in my practice, OCT is done in 100% of patients. I think that should be a, so once you have a patient has come for a cataract, any subtle, even if it is a small PD, even if it is small RP changes, see, this is shown, shown with a normal OCT, and that is how the counseling begins. So you have this problem, even if the RAM or anything shows that the patient has a pinhole vision of 6/9, which still insists that you can land up in a problem. And accordingly, as she has said, either it's a macular hole or a ERM, judge accordingly, do a surgery, combined surgery, or if it is something as dry AMD as he has said, put a bit, keep the patient a bit myopic and then do the surgery.
Yes.
I think that works.
For IL
wonders.
calculation also, if the
Post-op,
You cannot do OCT.
yeah, if the cataract is a white one or a black one, where we cannot
Yes.
see the retina, there is always, we write in the OPD record that visual prognosis is uncertain. And clearly telling the patient, maybe if you feel that something may go wrong, you can get it signed by the patient party also. That visual prognosis is guarded, and we may need second surgery for your restoration of vision.
But you must go for USG also. Because
But one
diabetic
thing,
patient-
Dejani, as he said, if there is a mature cataract, the first thing you should see is the other eye. We forget the basics of ophthalmology, basically.
Yes, yes. Yes.
The most important thing, Devasida,
Actually, we
This is the
eye
basics.
specialists,
This will
we
give you an
always
idea of
look
the-
both eyes.
Yeah.
The other eye is also, that will guide.
that
what-
will
what
guide
is
the
going
treatment
on.
of this eye.
And
Yes, sir, very true.
Well, welcome, Aniruddha, looking handsome. It's a wonderful shirt.
Dada,
So relax.
Babulalda, no one is looking more handsome than you are. You are looking much fitter after your UK term.
He's looking very handsome, I'm telling you. Welcome.
Aniruddha is probably second or
He-
third after
He's,
you and
he's,
Ojeda.
he's looking very relaxed on a Sunday morning.
So, Debjanidhi, for CSR, what would be your ideal operative management? Means probably the patient has CSR 6 months back, you are going ahead with cataract surgery. Would you give steroid or would you try just non-steroidal anti-inflammatory drops? And same question, Dr. Jayadev.
Yes, so really rare to see cataract and CSCR together. It was a very rare situation. But if in case we do see, then I would probably avoid the post-operative steroids if I know it's a trigger factor for that particular patient, because cataract surgery has become so minimally invasive now. You barely see any sort of significant post-op inflammation, which you can probably even manage with an NSAID. So I think that is one thing. And to add to the wonderfully presented talk on macular disorders in cataract, I think is very important, because like we spoke about, everybody expects 6/6 vision. So since we are not able to give that in these patients with macular disorders, just to give some numbers, we looked at the OCT of about 14,000 patients of undergoing cataract surgery on their OCTs. Out of them, around 3,500 of them had significant macular changes on the OCT, which was missed clinically. And out of which around 250 to 60 patients actually had their altered treatment plan based on the OCT. So I think the different plans that would then emerge is whether you want to do a combined approach wherein you have surgical conditions like macular holes, ERMs, and VMTs, or whether you want to do a combined approach, non-surgical, like an intravitreal or a steroid or an anti-VEGF, because you're seeing a CNVM or you're seeing coexisting edema, because in that age group you expect it to be there. Or whether you only want to explain the guarded prognosis where you see conditions like a PFT, and you know that this patient's vision loss is primarily because of the retina condition and not that. And the last category I would say is you go ahead with the cataract irrespective of a poor macula, because overall the visual quality will improve, the peripheral vision will still improve. So we can't defer a cataract surgery just because the macula is bad. So these are, I think, the different ways of approaching a macular case.
I would like to add another point. I think it is very important for documentation, because I get a lot of patients who complain that before the cataract, was it not identified or rather diagnosed? It's very difficult to counsel those patients. We tell, oh, maybe the cataract was very dense, so the operating surgeon could not see. But many a times the macular hole, ERM, was diagnosed after doing the cataract. So it is very important to document. You do the cataract surgery, but tell the patient that you have a problem in the retina, you address it after doing the cataract. I think that is very important.
Yes.
We'd like to proceed with our next talk by Sagarika Majumdar, and she's done her MBBS from Manipur and her MS and senior residency again from the same college. She's done her fellowship in surgical VR from Shushrutai Foundation and has various publication and presentations. Over to you, Sagarika, for your topic on post-cataract surgery, posterior segment complications and how to manage them.
Morning, everyone. Thank you, Sangeeta ma'am, for giving me this opportunity. Today, I'm going to talk about not very rare complications which we see day-to-day OT life. So all surgeries are fraught with complications, starting with low perforation, CME, PC rent with nucleus.
Could you please keep the mic in front of you, please? You're not audible.
Associated retinal detachment, suprachoroidal hemorrhage, post-op endophthalmitis. So coming to globe perforation, it's rare nowadays with the use of topical anesthesia. It can cause retinal tear, which can be managed with laser, and in severe cases, vitreous hemorrhage, retinal detachment, choroidal detachment. And CME, it's again common complication which occurs after 4 to 6 weeks of cataract surgeries, more involved retinopathy patients and lesser incidence in phaco. So it's very important to differentiate it from DME, where PCME is having higher central retinal thickness, solely internuclear. In every case, serious macular detachment is seen. And whereas in other hand, DME will have parafoveal thickening, presence of microaneurysm, hard exudates. So treatment with there is no standard treatment for this, starting with topical corticosteroid NSAIDs, then subtenon steroid, then in resistant cases, intravitreal injection, steroid implants, and if vitreous incarceration or VMT is present, surgery is the only resort. NSAIDs are prophylactically used in diabetic retinopathy cases, but not for all cases. So another very unwanted complication is posterior capsular tear. So as soon as we diagnose this, it's very important to lower all the parameters and maintain the AC with use of OVD before taking out the phaco probe, and do gentle anterior vitrectomy. And then if sulcus is present, put the lens. And if it's not there, secondary IOL should be put, and do not leave the eye effective. And in case of nucleus drop, 3 things are very important to remember. One is there should not be any fishing, as it causes iatrogenic retinal tear, which land up to retinal detachment. And clear the cortex vitreous from anterior chamber to make the cornea clear. And before referral, always suture the wound. And suprachoroidal hemorrhage, it's rare complication and rarer in cataract than other surgeries. We all know the signs. In severe cases where retinal apposition is seen, close the wound and call that patient after 1 to 2 weeks. And if repeat the B scan, if liquefaction occurs, then opt for posterior sclerotomy. That is 1 to 2 mm sclerotomy wound, which is placed 3 to 4 mm behind the limbus, where the collection is the largest. And preventive measures that withhold anticoagulants and antiplatelets 5 to 7 days before surgery, and management of persistent hypertension and cough. Coming to the last point, that is post-op endophthalmitis, where India is having 0.04 to 4% incidence, and leading organism is gram-positive, especially MRSA, followed by gram-negative and fungi. We all know the presentation. These are the different presentation. First one is P. acne in chronic endo, and in fungal endophthalmitis, where we can see severe anterior segment inflammation, and nocardia is having anterior segment involvement more than the posterior one. Diagnostics by doing paracentesis 0.1 to 0.2 ml, vitreous biopsy is the gold standard one. And B-scan, it doesn't have any diagnostic role, but we need to do it to rule out retinal detachment, intraocular foreign body retained lens matter, and whether it has panophthalmitis occur or not by seeing subtenon fluid, and after giving injection to know whether condition has improved or not by seeing vitritis is present or not. And management is intravitreal injection, which covers both gram positive and negative. Do not wait for culture report before giving injection. Tap for stain and culture. Vancomycin, ceftazidime, and dexa. But dexamethasone is having a steroid is having a contradictory role in case of diabetic and fungal. It's contraindicated. According to EVS, systemic antibiotic doesn't have any role, but studies are saying that systemic fluoroquinolone, especially moxifloxacin, have role to reduce the infection. So when to take this case for vitrectomy, when vision is less than hand movement, or there won't be any improvement after giving 2 intravitreal injection. In cases of fungal or P. acne or diabetic cases, vitrectomy should be done. And there is 2 school of thought where according to EVS, 50% core vitrectomy should be done. And according to CEV, that is complete and early vitrectomy study for endophthalmitis, it said that induce the PVT and do complete vitrectomy. Use of silicone oil, again, if severe inflammation is there, vasculitis, necrotic retina, to prevent further retinal detachment, that is used as tamponade. And in severe cases, radical vitrectomy is done. So coming to the take-home message is, if globe perforation happens, patch the eye and look for any retinal tear. If media is hazy, then opt for B-scan. If recalcitrant PCMA is there, ask for second opinion. If PCR happens, then post-op periphery checkup is very important, and always rule out PCME. If suprachoroidal hemorrhage and nucleus drop happens, suture the wound before referral. And post-op endophthalmitis, always rule out toxic anterior segment syndrome. And if diagnosis is confirmed, then at least 1 dose of intravitreal antibiotic should be given before referral. Thank you.
Wonderful. Women wishing the Father's Day, and happy Father's Day to all the fathers here. Well, wonderful.
What about the grandfathers?
So that is itself a father, father square.
Not at all. We are grandfathers now, na?
Yes. So that's a
So
father
I
square.
think why did you miss TSS?
Sir, I didn't describe, but I have said this. We need to rule out.
She's mentioned, sorry. Is any open to anyone? The one thing I can tell you, if you have a complication of cataract, the first thing you should do, keep your head cool. Don't be excited. That is the only take-home message.
So I would ask an opinion for the house. If you are seeing a patient in your clinic, evening clinic, where you don't have an operation theater, a patient with post-op endophthalmitis, what should be the ideal steps next?
Phone Aniruddha.
No, is it? Selling phone Aniruddha. Aniruddha will be injection here.
If he's not in his club.
Can be given in
Can give, given. We
Yes,
have
yes,
got-
highly.
Arvind, yeah, Arvind has got that, every clinic should have, if you're a operating surgeon and if you can do it, I mean, most of us, all the cataract surgeons are trained to give intravitreal. So that's
That should be the take-home message rather than leaving the patient
for next day, 24 hours.
Intravitreal is an OPD procedure, basically.
Yeah, yeah.
Can always be done. That is a take-home message.
So everyone in their clinic should be having an intravitreal kit. We would like it to get expired, but and get a fresh one. But definitely we need to keep that as a red box. Antibiotic. Intravitreal antibiotics.
Antibiotics, yeah. Not anti-VEGF. we are no. See, this is started in USA, so we are just following them. They're being. Present generation, all cataract surgeons know, sir. I mean, those are trained in last 5, 7, 10 years, whoever comes to us just for fellowship, anything, they all are, I mean, that is to be, when we train, we are not taught. But today when, yeah, that's there in it.
RD is very bad. So just let it go. I mean, if it's sinking somebody else's trouble, that is. But of course, that doesn't mean that you don't take care of of course, the next talk will be talking about AFib management. But at any point of time, yeah, the retina surgeon may not be very well versed with putting an IOL in the sulcus. Every case does not really need an SF-IOL. So even if there is some amount of capsular support, please go ahead and put the IOL and then send for removal of the nucleus. But having said that, please don't put it if there's an IOL that's dropped. So that's another thing we have seen. Patient, they'll put an IOL and send, and there's an IOL in the vitreous. So it's so difficult, to remove it once there are 2 IOLs. So we've had those issues, couple of cases. So just wanted to add to that. For the end.
I think from the society point of view, please circulate this. It will be very easier for everyone. Many do not have the simpler parts. So from the society, if you can circulate this to be kept in the OT, I think that will be very good.
Thank you.
So we come to our keynote address by none other than Dr. Chaitra Jayadev, who's flown all the way here from Bangalore, and she is the head of vitreoretinal services at Narayan Netralaya and Bangalore, and currently the joint secretary of AIOS and Vitreoretina Surgeons of Indian Society, and chairperson scientific committee for the Karnataka Ophthalmic Society. With a flair of research and scientific writing, Dr. Chaitra has over 140 PubMed indexed articles. She completed her PhD from the Maastricht University, Netherlands, and Healthcare Leadership Program from the Harvard Medical School. Dr. Chaitra, we are indeed privileged to have you here. And this is again another secret which I'm letting out in the open. She's also doing her law right now. So I know she is going to, be a law representative for us and guide us in the future for all these things. Over to you, ma'am, please.
Thank you, Swati and Sangeeta, for having me here. And Sangeeta mentioned this is a platform for young female ophthalmologists. So I don't really qualify for that, but nonetheless, today I'll be speaking on aphakia management because this is a anterior and a posterior segment combined session. And I will be briefly talking about the different techniques that are available and how to go about planning the IOL. Since I think that is some very important topic because we do see a lot of patients with intraoperative complications. And since Swati was speaking about law, I'm pursuing a medical legal course, basically about law and ethics related to medicine. It's a very interesting, course to do if anybody is interested. It's given out by the National Law School. It's quite a tough program, lots to study, lot of bare acts to know. But eventually, especially if you're, in a institute or even in a private practice, it somehow will give you some sort of a skill set to deal with the, looming medical negligence thing that can come in. But I must say that when you read some of these acts and the government has put in some guidelines, especially with the new Epidemics Disease Act, they have come in with a law that says that nobody can, hurt you physically or mentally, and you are eligible for a compensation of twice the losses. So I think we lost one recent doctor, she committed suicide because she was scared. So had she known these facts that you cannot be prosecuted, she probably wouldn't have taken that extreme set. So at least for this kind of knowledge, I think is very important. He's speaking on aphakia management, no financial disclosures there. So what does aphakia mean? It means the absence of the crystalline lens from the eye. Here we can see a normal eye where the lens is present and aphakic eye where the lens is missing. So the other way to look at it optically is when the lens is actually missing from the pupillary area and it does not take part in the refraction. So here also when you look at it in the slit lamp, you will still write it as aphakia, even though the lens is probably dislocated and lying somewhere in the vitreous. So what are the different causes for aphakia? There could be congenital absence, pretty rare, due to absorption of the lens matter itself after trauma. Patient comes with history in young age, some trauma, and you don't even see the lens there, no surgical history there. There might be a traumatic extrusion itself, a posterior dislocation like we just spoke about, a surgical aphakia when it was left without an IOL, and many disorders that are genetic and hereditary. So what are the different surgical managements? I'm not going into the non-surgical managements because I think that's expected from us now, that we do give them more than spectacles and contact lens correction, because that used to be the norm some time back. But even for children now, we do go ahead and give them the advantage of having a lens. So you can put a PCIOL in the sulcus if there is adequate capsular support. An angle supported or an ACIOL is something which could be done sometime in the past, but now that we have other options, I think ACIOL, though a well done ACIOL is pretty good, we have seen some very good cases like this, which is many decades of ACIOL, but still doing well. An iris claw lens, I think, is quite good for people who are comfortable with anterior segment surgery, but somebody like us, we're not very comfortable placing an iris claw. We'll speak about the advantages and disadvantages in the next few slides. So this is an iris claw, gives pretty good centration, and the pupillary dilatation is not really affected in all patients. And then you have the scleral fixated lenses. So these are some of the types of techniques that we've been doing at our institute. Either it could be a tuck or a flange technique. So these are the advantages and disadvantages. Just to speak about the main ones, ACIOL I think is very easy to perform, but then you have angle damage, you have PAS, you could have glaucoma issues as well. Then you have iris fixated IOLs, quick to perform if you're skilled in this particular IOL. But sometimes pupillary dilatation can be hampered. We've seen some of them coming with poor dilatation, and those patients whom you have to screen for diabetic retinopathy or peripheral tears, holes, becomes very difficult. And then SFIOL, it's in the physiological position. So obviously, when you look at the refraction, it's pretty good. But you need these instruments. It's difficult to do all techniques of SFIOL without having a vitrectomy machine and some of the other things like cautery. You might need special instruments as well. Now, having said that, I think SFIOL is the one cataract related surgery that has the most number of techniques and modifications and adaptations and IOLs. So it's impossible really to go over each one of them. They're all available online. I'll just speak about a couple of them. So SFIOL is indicated in intraoperative posterocapsular rupture when a lens could not be placed, a planned ICC or a lensectomy in patients who had dislocated or subluxated lenses, intraoperative zonular dehiscence as well. These are some of the indications where we could potentially be using an SFIOL. So if you look at the patient selection, it is useful in patients with iris tissue loss because you can't put an iris claw for them. In patients with glaucoma, again, you would want to avoid iris claw or any of the, even the anterochamber IOLs. Corneal endothelial loss because you're expecting decompensation if you place it in the anterior chamber. So these are some of the patients in which SFIOL is definitely beneficial, but it should be avoided in patients with limbal scarring, particularly because you'll have to tuck it there. You don't want to cause further or late dislocation of the lenses. Also in patients with blebs, I would avoid SFIOL. Microphthalmus, microcornea, because you don't have smaller lenses that you can use in these patients as an SFIOL. Any bleeding disorders, because we see a lot of patients coming with post-op bleeds as well, and retinal degeneration detachment. I think you can be choosy about these patients based on how severe the disease is. So these are the literature that shows the different IOL selections that are available. I'll briefly talk about a couple of them. So this is a single piece PMMA with eyelets by Orolab that is used when you need to use a suture fixation. So this is very good. This is a pretty good lens because it has the eyelets through which you can pass the suture material. Then you also have the 3-piece by Orolab for sutureless technique. So these are, I think, some of the most commonly used IOLs for SFIOL. Other than that, you have the Alcon PMMA. You also have the Bausch & Lomb Envista. These are some of the other ones. The Zeiss CT Lucia is also very popularly used for SFIOL, and the Technis lens as well. So most of them would prefer to use a 3-piece. Some of them are also now doing SFIOLs with a foldable IOL. But then, like I said, each person's comfort level matters for the technique that's used. Now, this is important. You need to know the IOL power calculations because it's not the same as you're doing it for a regular IOL. It has to be done in the aphakia mode on the A-scan biometry in the absence of lens from the pupillary area since it does not take part in the refraction. The SFIOL is about 0.5 millimeter anterior than when it is placed in the capsular bag. So therefore, you have to reduce the power to the same to get the same refractive outcome. Reduce the IOL power by about 1 diopter for an average eye. And then for larger or myopic eyes, you can reduce it by about 0.5 diopter, and for hyperopic by about 1.5 diopter. So this is a general rule that you can follow if you want to do it in practice. Suppose suddenly you need to do the IOL on table, you have not really done the calculation, you can use it as a rough estimate. There's also something called as the rule of nines method for sulcus IOL power approximation. So this is the original power and the adjustment that you'll have to make. So 0 to 9, no change. Plus 9.5 to plus 18, you reduce it by 0.5, and 18.5 to 27 by -1, and 27.5 by -1.5. So this is a general rough rule. So the surgical principles, the IOL should be placed correctly in the sulcus. So the haptic should be placed and fixed exactly 180 degrees apart. If you don't do that, you have a risk of tilt, and then again the refraction then gets affected. The corneal center and the points for haptic fixation should be in a straight line, again to avoid tilting and chafing. Suture should penetrate only the sulcus and not adjacent to the iris or the ciliary body, because I've seen sometimes the suture material has actually passed through the iris and come out. So that time again you can have pigment dispersion glaucoma. And the IOL chosen must be so designed that it suits the anatomical needs of the procedure, the technique that you're using, also the anatomy of that particular eye itself. So this was what I meant by you can't pass the suture through the root of the iris. Sometimes you can do that if you don't go perpendicular to the sclera. So these are some of the older techniques, and the complications that arose with these techniques were vitreous in AC, elevated IOP, RD, corneal complications, and breakage of the suture, retinal detachment as well. These are some of the older techniques and what the outcomes were. So then came the sutureless, therefore, because you saw a lot of suture erosion and dislocation, late dislocation. So these are the different techniques that I've listed out. It's impossible to go through all of them, but they're all available online. YouTube videos are there, so you can go through a lot of them. The 27 gauge one is the latest technique, wherein you're using the same insertion also to place the IOL. So you don't have to make another different sclerotomy. So that's the advantage of using the 27 gauge and therefore sutureless. So this is the VRS technique that a lot of our surgeons in our institute do. So basically here we have a 1 millimeter blade that is specially available. This is a technique by Dr. VR Saravanan from Arvind. So it's quite popular, this technique. This is a sutureless technique wherein you're tucking the IOL. So like I mentioned, 180 degrees apart, you make the tunnels and you insert a micro forceps and pull out the haptic through the using the forceps on either side. So once you pull it out from either side, you just use a forceps to insert it into the pre-made tunnels. So this gives a fairly good centration. Can also be done if the eye doesn't have a lot of vitreous loss. You've done a decent, anterior vitrectomy. You don't have to really be worrying too much about this because there's a lot of manipulation in this particular technique. So it gives you good centration. So this is the VRS technique. We have quite a lot of experience at our center with this technique. So there you use a forceps and release the haptic. So these are some of the post-op images of patients who have undergone the VRS technique. Pretty good outcomes in the first post-operative day itself. The other technique that we are using is something called as the double flange technique. You've all heard of Yamane and his technique of making flanges. So this is a similar technique, and I think Dr. Sri Ganesh calls it the dumbbell technique. But what they've been using is the Bowie cautery, which again you'll have to buy separately, and Bowie sometimes doesn't really work well. So in this, you're using 30 gauge needles. I use 30 instead of 26 gauge. Pass the suture 60 proline through the 30 gauge, insert it on either side and bring it out. Then you pass the suture from about downwards. So that's how you have to align it, and then create a flange using an endo laser. I'm using an endo laser probe. I use 130 continuous laser power mode. With this, you have a very controlled way of making the flanges. You're making the flanges externally, so you have a lot of control. And then you just pull it out, center it, trim the suture material, and create the flange again. There you can see the flange being made. This again gives extremely good centration, and it's quite an easy technique to perform. So I've been doing this technique, and these are some of the post-op pictures. So the images, you can see the centration in the top right. It's pretty good centration, and you can also use it in patients with iris tissue loss. And the left images are of the same patient, one eye that she underwent 2 days ago, and this the eye below she's undergone about 6 to 8 months ago. So the conjunctiva eventually grows over the flange, and you can see that it gets buried and covered, so it stays quite stable. So I must tell you some of the disadvantages of doing this particular technique is we have about experience of about a year or so, but we don't know how long it will stay. We don't know about suture breakage. We don't know about the dislocation so far. So I still don't have long-term experience with the technique. But other than that, we have also done an aniridic IOL with this technique, and that patient is doing very well because aniridic IOLs are a little difficult to get and also to place because you need to do a large, limbal incision to insert it. We've even done one eye. And the advantage here again is suppose there is some sort of scarring temporally and nasally. I've also placed one IOL with the flange at the superior and inferior cloacas. So that's also worked well. So with our experience, these are some of the complications that we've had. Most often we've seen RDs in those patients with high myopia or those who have undergone multiple surgeries previously. Choroidal detachments also we've seen, post-op drop in IOP with some amount of CDs we've seen. So who should do the surgeries? I think we were discussing this during tea, and Dr. Paul is smiling because we both discussed, should it be an anterior segment surgeon or should it be a posterior segment surgeon? So how many anterior segment surgeons are doing SFIOLs? You're a pan-ophthalmologist, is it? Okay, how many retina surgeons doing SFIOLs here?
All
Okay.
retina surgeons
I think
do
majority wins. So we're all posterior segment doing. So there are certain conditions in which cases in which I think it makes sense for a retina surgeon to do it, especially when you're having a drop, already pre-existing retinal conditions there, because you don't know what you're tugging at. Every time you pass a suture, every time you pull out a haptic, you will be exerting some pressure on the base, you will be having tears. So if the vitrectomy is required, then it has to be a retina surgeon. And this particular study has shown what are the complications between the PPV group and the antrovitrectomy only group. Eyes in whom the SFIL was placed after just an antrovitrectomy were more likely to develop high IOP and lens dislocation compared to those who underwent a complete vitrectomy with an SFIL. So to conclude, we do have improved visual acuity outcomes with all the new techniques of SFIL, shortened surgical time, 4-point fixation. We know all that. At least the old timers will know these different techniques and how long it used to take and how frustrating it used to be. We used to have a lot of complications, but not anymore. We have very good IOL centration with the new techniques. And there ends my talk. Thank you so much.
Thank you, Dr. Chaitra. What has Dr. Amaiti, what has been your experience with iris claw lenses, and what would you prefer, SFIL or iris claw?
I think for the last 8 years, I've been doing iris claw, and it's pretty much stable, and the post-op complication is almost not there. I just wanted to ask Chaitra, like you flange this haptic and it is exposed. So do this patient complain of some foreign body sensation, or because it is exposed? So,
That is only immediate post-op period if you have not buried it.
so isn't it better to have a flap and put it inside?
I'm trying on a modification. So basically you've already inserted it before making the flap. So there are two options. Either I make the flap first and then insert it through the flap, make the flange and cover it with the spiral flap is what you're talking about. But most of these patients, the conjunctivalization happens very rapidly. The youngest patient that I've done this technique for is a 7-year-old boy who had even loss of conjunctival tissue, but eventually it got covered by tissue and he has absolutely no complaints of pricking, poking, none of them. Not even as much as our vicral sutures, because it's a very flat surface. The flange that you create is flat. It's very smooth and it's very flat. So no complaints as far as the pricking and thing goes. But like I said, it is better to cover it with the conjunctiva as much as possible, and it stays there. I'm not really seeing it erode the conjunctiva at all.
Will it not expose like constant?
No, like I said, I have about a year's follow-up. Okay. Let's see how.
Recently in AIS, we saw a very unique technique of putting some autologous blood underneath the flap, and it does pretty well.
Okay.
Just in a replacement of glue.
Glue, yeah. If you don't have glue, unfortunately for glue, we have to depend on the plastic people. If they've used glue, then we can use it.
I think this autologous blood is a good alternative to glue.
Yeah, so I'm trying to do a modification wherein I make a flap, then pass the suture and then cover it. And then once you cover the conjunctiva, you don't really need to even suture the flap. Let's see how that goes. But then you can't tighten it. Sometimes what happens is if you have not pulled the suture to taut and done the flanges, it tends to become a little loose. There's one patient where there was a 1 millimeter extra, so I just took him up to OT the next day and I tightened the flange, made it shorter.
Just to follow up what Aniruddha said, we have been doing the glue dial technique for last 7 or 8 years, then switched on to intrascleral. Right now, I'm into Yamanis more than anything else. But then, as he has said, over a period of time, I've seen, only last week I had one of my glue dial patient, the other one haptic has come off. Now, over a period of time, as you say, your technique where you are just tucking it, I have done a lot in between, just intrascleral tuck and longer haptic you put it. But over a period of time, and maybe the patients are not coming back to me, but seeing one patient of that, the same way as you are doing your SFIL over a period of time. So I think there's again a move towards those Gore-Tex sutures being used. So this is something.
Not available that easily.
I think there are. I think the Disha people has made a way out of it. I mean, they buy a brick and then charge for. Yeah, 4,000. No, yeah, I know. You can. Cardiologists make a small piece. I'm saying this is the, because whatever we do, this even this the technique that you showed where it is as you said exposure, yeah, because the technique that you showed, the Sri Ganesha's technique, which is going straight down. So unlike the Yamanis technique where you are having an intrascleral part and then you are having a bit of you're making it a bulb flange.
This is not the haptic.
This is the suture. So again, that suture, whether that as this exposure, it does expose over a period of time. How much? Because the sclera, the conjunctiva. We have had patients who are actually the glue dial in the earliest. We had a scleral, flap over it. But over a period of time, I can see this blue thing quite exposed. I mean, you feel.
No, but if that is not creating a complication, I
Yeah,
don't think
it's-
it's a matter. I think two things that we need to be worried about is infection.
Yeah,
If you-
infection,
and
where?
second, I'm more concerned about infection with the suture because, I don't know whether it's making a nidus, for a severe
Future,
conjunctivitis.
yeah, and if
Second
you-
is the dislocation. So I think if those, even if we have some amount of suture exposure, if it is not creating a complication, I think it's okay, suture or haptic, because even in the tuck technique, you can see the haptic there. Yeah, if it's placed superficial, you can see it.
Do you think intrascleral tunnel, a small place, it should be tunneled and then make a flange would be more stable than
Yes,
a
more
direct.
than a tunnel, a flap. I think a flap makes more sense. The tunnel, only if you're tucking, you need the tunnel. In this, we're not tucking. The reason why I showed this technique is because a lot of it is extraocular and it's very easy for a beginner to start off with. And eventually, once you get comfortable, you can, innovate and make your own techniques, because SFIL, I think literally every few months there's a new technique that's coming in, which works best in your hands and which works safe in your hands, I think is what we need to do.
Yeah, but then why did you think of the suture rather than the haptic, multi-piece haptic?
So the
flanging?
reason is it causes shortening. The titration is very difficult. Suppose you tuck more on one side, you're left short here. And when you're trying to tuck this comes in. With the suture, you have your entire haptic, and this is also very good for growing eyes. With growing eyes, like I said, I've done it for a pediatric patient because you don't know, what the give is there with the lens. Suppose you've tucked it in, you can't obviously, expect that the eye will last a lifetime. Whereas with the suture, it's just, kept in position there, and the entire IOL length is used. That's the reason why we thought of suture. Thank you so much, and thanks to all of you all for this opportunity.
Thank you, Dr. Chaitra. Do we have any further questions from the audience? Yes, please.
I would like to share about my experience with Gore-Tex suture for SFL. I am doing this for last 3 years, and I have seen, I think we have follow-up for more than 5 years of patient, and I felt it quite manipulating the IOL with Gore-Tex suture is quite easy. The suture breakage intraoperatively as well as post-operatively, what happens with Prolene is not there, and if you we can buddy the knot very easily within the sclera, and the chances of exposure in those cases will be very less.
Thank you so much. So I think I would like to invite, thank the chairperson and on the panelists, but more importantly, I would ask our chairperson, Dr. Abhijit Ghosh, to please hand over a token of appreciation to Dr. Chaitra. So please do the honors for our panelists, Dr. Ajay Paul sir. Dr. Siddharth Ghosh sir, Dr. Shugotopal sir. I would ask Dr. Chaitra to please thank our chairperson, sir. I would ask Dr. Sunil Surana to please felicitate our speakers. He has been a core member in OphthaEva, coining the term, and also founder for this. Dr. Devjani. Didi.
It's an honor to get the felicitation from my old friend.
Dr. Sagarika. May I request the session one speakers to have a group photograph, please, before we hand over the session to.
Just a second. Before that, ma'am, may I request Dr. Anurito Maiti to please felicitate Dr. Swati, please.
Thank you.
She was like, it's me only. How can I ask?
Abhijit, sir. Shugatada. Sagarika, please come. Now we're going to have a very great session moderated by Dr. Surbi and Dr. Sangeeta and Dr. Muna Bhende ma'am, who's joined with us over Zoom. Muna ma'am, good morning.
Yeah, good morning.
Ma'am, you need to unmute.
I'm on mute.
Okay, yes. Now we can hear. So we are all looking forward to gaining insights from you. And, it's very nice to see you on a Sunday morning, keeping you occupied even on Sundays.
Thank you all for the invitation, and I would have loved to be in Kolkata, but I have a family commitment which doesn't permit me to leave this weekend. So, yeah.
No worries, ma'am.
Yeah. Would you like me to share my screen? Just to see if you can see my slides?
Yes, ma'am. Just a little audio visual refining. We're refining it just a little.
Sure.
Fan playing in your place? Can you switch it off for 5 minutes?
Sorry, the fan.
Yes, ma'am. Some background noise is coming because of the fan. Ceiling fan.
Okay, 1 second.
Starting with the second session for today, which is medical and surgical retina. Let me start with inviting the chairperson for this session, Dr. P.N. Biswal. So
Is it better now?
Yes, ma'am.
The panelists for the session are Dr. Anirudh Maiti, sir, Dr. Devmalya Das, sir, Dr. Krishnendu Nandi, sir, Dr. Muna Bhinde, ma'am, Dr. Saptarishi Majumdar sir, Dr. Somin Mandal sir, Dr. Sudipta Das. So
Sir,
with this, we start
sir.
with the session. It's a privilege to have Muna ma'am with us today. Ma'am needs no introduction. She's a teacher par excellence. She has trained numerous young ophthalmologists, and I'll just introduce ma'am. So ma'am has done her MBBS from Kasturba Medical College, Bangalore, followed by MS Ophthalmology from RIO Minto, Bangalore. She did her fellowship in surgical vitreoretina from Medical Research Foundation, SN Chennai. After that, she joined SN as faculty since 1994. She's currently the senior consultant and deputy director at SN Chennai. She has various publications, textbooks, and she has published atlases. And she's actively involved in teaching and training of ophthalmology postgraduates, fellows, and optometrists. Welcome, ma'am.
Thank you so much. Thank you, Dr. Sangeeta and Dr. Swati, for the kind invitation. I'm glad to see this forum and that lots of people on a Sunday morning. Let me just share my screen. Can you see my slides?
Yes, ma'am.
Today I will be speaking to you on surgery for retinal detachment due to viral retinitis. There are certain challenges and I would be speaking about them. Let me start with the case of an elderly gentleman, an elderly diabetic who presented with redness and loss of vision in the right eye of 2 weeks duration. His vision was hand movements. He had dense vitritis, mutton fat keratic precipitates, and you could see hazily there was a peripheral necrotizing retinitis. The left eye was normal. His anterior chamber tap was showed a PCR positivity for VZV. The patient was started on topical and systemic antivirals and steroids. It showed improvement in inflammation, healing of necrotic patches, but as we know in viral retinitis, especially acute retinal necrosis, the patient developed retinal detachment after a month. He also had steroid-induced worsening of diabetes and decided to wait for the surgery. This was his fundus picture 1 month after presentation. You hazily see there's a retinal detachment, vitreous opacities persist. And ultimately, he agreed for surgery. We first took an undiluted vitreous aspirate and did a complete vitrectomy, including PVD injection. If you look carefully here, you see how the vitreous is so sticky. And finally, we are able to induce the posterior hyaloid detachment. And now the opaque inflamed vitreous is being excised. What you need to see in this is the presence of so much of inflammation when you have a patient with acute retinal necrosis. As we reach the periphery, you see these large areas of moth-eaten appearance, and this is almost 360 degree with necrotic retina that is now being excised. The vitreous is all adherent to this area. And this patient also had some PVR. So the PVR membranes are being removed. Here you see some more membranes being removed. And then perfluorocarbon liquid attached the retina at the posterior pole. Cautery, because the areas of necrosis were present 360 degrees. So I did a 360 degree retinotomy. Here you see that all the necrotic retina with holes is being excised. All this anterior flap is being excised. And this was followed by more PFCL air silicon oil exchange after doing a 360 degree laser photocoagulation. 2 days post-operatively, the eye was quiet and the retina was attached, and 8 weeks post-operatively, best corrected vision was 636 NAP with a dense cataract and normal intraocular vision. What is most important is the patient needed to continue the antivirals in the postoperative period, which is something we tend to forget when we deal with retinal detachments. And this is what is different in these eyes. And you may sometimes need to continue the antivirals for a period of almost 6 months, as was done in our patient. So retinal detachments in eyes with viral retinitis fall under two major categories, whether the patient is immunocompromised or immunocompetent. However, the common pathogenesis is that inflammation leads to necrosis, multiple retinal breaks, and retinal detachment. And the difference in the clinical response depends on the immune status of the individual. There are common challenges that one would face. The most important is managing the infection. And managing viral retinitis is not simple. Preventing or managing the retinal detachment, and managing both infection and retinal detachment, which can sometimes occur concurrently. And also it's important to look at the systemic status. Many of these patients are diabetics, many of them have HIV. So it's important that we keep a watch on all these other systemic conditions as well. So what about acute retinal necrosis? It's caused by the herpes group of viruses and traditionally occurs in immunocompetent young adults, starting as one or more discrete foci of retinal necrosis in the periphery associated with occlusive arteriolar vasculopathy. There is rapid disease progression in the absence of therapy and sometimes even in the presence of early intervention. And this is typically circumferential. And there is a prominent vitreous or anterior chamber inflammatory reaction. Rhegmatogenous retinal detachment is usually a late complication which develops at 1 to 2 months after presentation. You can also have tractional or combined retinal detachments. And here you see a typical picture of the large retinal breaks in the periphery with this moth-eaten appearance of the retina. What is also important to know is that the fellow eye can be involved in almost a third of cases and usually within 1 to 6 weeks. And the involvement may start even with normal vision. So it's important to periodically evaluate the other eye for development of acute retinal necrosis. Once the diagnosis is established, you would confirm it either with an AC tap or a vitreous biopsy, start the patient on either oral or intravenous antivirals along with systemic steroids. Coming to surgery, vitrectomy could be diagnostic where you're not able to get vitreous sample. So even if we do a vitrectomy for a patient with retinal detachment, we do send a sample for possible viral studies. Vitrectomy can be optical, where in the presence of dense vitritis, you may not be able to see the retina or treat retinal breaks that occur. And vitrectomy is also required as part of management of retinal detachment or vitreous hemorrhage, which are known complications of viral retinitis. Laser photocoagulation can rarely be done if the media is clear enough and you see the retinal breaks, the retina is attached. You can do laser to prevent a retinal detachment. Rarely, if the patient is physically unfit, you may want to do a macular sparing demarcation of an inferior retinal detachment. Very rarely, if the vitritis is clear and the media is very clear, you may choose to do a scleral buckle in a patient with retinal detachment and peripheral breaks. Can we prevent RD? It's a little difficult in acute retinal necrosis because the media is hazy, which makes it difficult to identify and treat the breaks. Previously, there used to be studies which demonstrated the use of vitrectomy with acyclovir lavage, followed by endolaser to the breaks and endotamponade, but this was not found to be very effective. We know we can get progressive involvement of retina beyond the area of laser lavage if the infection is uncontrolled. And rarely you have multiple large posterior necrotic breaks that cannot be treated with laser. As I showed you, the retinal breaks are large, atrophic, and occur at the junction of normal and inflamed retina. And they can have significant traction, epiretinal base scarring, and vitreous-based fibrosis, which reflects the robust immune system of the individual. Sometimes we may see this in eyes with healed retinitis, where the eye looks otherwise quiet. You may have a long-standing retinal detachment with peripheral retinal breaks and a moth-eaten retina. Sometimes it's more challenging if there is active retinitis concurrently. The surgical challenges is you have a sticky vitreous with adherent posterior hyaloid. You can have a thin necrotic retina. Here you see this video showing the multiple retinal breaks in a sieve-like fashion. You can have peripheral fibrosis, which can lead to traction and also postoperative hypotonia. PVR changes can be severe. You can have an exaggerated postoperative inflammatory response, which has to be predicted and treated accordingly. And we do need long-term systemic medication and prolonged silicone oil tamponade because many of these patients develop a severe recurrence once silicone oil is removed. Coming to CNV retinitis, this is the other viral retinitis associated with retinal detachment. The presentation is quite different because it's common in immunosuppressed individuals. Hence, there is none or minimal vitreous inflammation. You hardly ever see a patient with CNV retinitis having PVR unless they also have immune recovery vitritis. It starts off as a hemorrhagic retinitis, which is perivascular in distribution. Rarely a very severe form can present with frosted branch angiitis and generally has a poor response to antivirals. The retinal detachment is almost similar to ARN. You have heel retinitis, atrophic scar tissue as opposed to fibrous scar tissue there. And this gives rise to retinal breaks. And as you see in this picture here, because of the lack of contrast within these areas of atrophy, it may be a little difficult to identify the breaks preoperatively. Severe PVR and vitritis is extremely unusual in a patient with CNV retinitis. So if you see a patient with retinal necrosis and PVR, there are two possibilities. It's either acute retinal necrosis due to the herpes virus group, or the patient has immune recovery vitritis if he has HIV. Exudative retinal detachments may also occur in patients when they present with this form of severe frosted branch angiitis. Again, the treatment includes both medical and surgical management, and of course, heart therapy, because most patients with CNV retinitis have HIV, though many of them are post-renal transplant as well. Again, surgical techniques, demarcation laser, if the retinal detachment is peripheral with small breaks and the patient is physically unfit. Rarely a scleral buckle, but vitrectomy with silicone oil is the choice in most cases. And this is a patient with CNV retinitis. Here you see the media is fairly clear. Again, you have these large atrophic breaks. You have to carefully induce the posterior hyaloid. Here you see that the vitreous is fairly clear. You may have dense lesions only at the border of healthy and unhealthy retina. At this point, it's important to carefully look for the retinal breaks, do a fluid hair exchange. Here you see the vitreous is fairly clear and the trimming is going on at the edge of the magnetic retina. Some more trimming is going on. Yes. And finally, you do a fluid air exchange, silicone oil, tamponade, and insert large is optional. As I mentioned earlier, the vitreous is almost clear in all these patients, hardly any PVR. Here you see the large area of heel retinitis showing atrophy, and you keep carefully clearing the vitreous. And now here you see a tiny retinal break with subretinal fluid leaking out. The challenges, again, are the presence of active retinitis along with retinal detachment, the increasing incidence of PVR in the heart era. Previously, we did not expect the patients to live long, so we did not expect to remove the silicone oil, but now I'm removing silicone oil for many of my patients who are living normal lives many years later. We do need to look for recurrent infection in the postoperative period. We need to watch for PVR if the patient develops immune recovery vitritis. And again, as in all viral retinitis, it's important to counsel the patient to continue systemic medication postoperative. Thank you for your patience. I'll be happy to take any questions.
I think our audience, they do have some questions. So I think Dr. Maiti has some questions.
Excellent presentation as usual. Just a query, in these cases of ARN, do you do a prophylactic laser if there is no break as well? Because although it is a controversial, but it was practiced and it prevented retinal detachment to some extent.
Yeah, if you're able to see well enough, because that is very rare in acute retinal necrosis. Because acute retinal necrosis tends to have more severe vitritis, and the retina is always edematous. So if you're able to do it, fine. I have tried once or twice, but there are areas that we couldn't see, so we couldn't treat. The retinitis progresses. I have once done a vitrectomy to clear the vitreous and then treated the retinal breaks. But without that, it is a little difficult to get a good result. You can treat, but usually these eyes are very inflamed and it doesn't work as well.
I think generally we do in a multiple sitting, because obviously in a single sitting it's not possible.
Yeah.
Bonding, that is the time we can do.
Yeah.
Complete the razor.
Yes.
Hello, good morning, ma'am.
Good morning.
Obviously, that was an excellent presentation.
Thank you.
My question was, what is the role, according to you, of band buckle, 360-degree buckle, when you are doing a surgery for ARN?
For ARN, sometimes if I'm trying to preserve the lens, then I may put an encerclage. But if there is 360-degree necrotic retina, like there was in the first case I showed, then there is no rule. So probably I wouldn't put it in the start of surgery. And once I've cleared everything, because media is never very clear in these eyes. But in ARN and CMB, we tend to use very little of belt buckle. Because you're usually cutting off the necrotic retina in the belt.
So whenever there's necrotic retina in the periphery, you routinely remove all the necrotic retina that is possible.
Yeah, you can leave it alone in CMB because it doesn't incite much inflammation. But in ARN, because they are all very robust immunologically, then the chances of PVR is much higher in ARN than in but there is a risk of hypotony because you do such extensive. So you have to weigh one against the other.
Any more questions?
Good morning, madam. Krishnendu here.
Hi, Krishnendu. Good morning.
Fine, madam. And madam,
Yeah.
your choice of oil in these cases, whether you like to put 1000 or 1300 centristroke or 5000 from the start, from the first surgery, not at the resurgery.
Previously, when we were doing HIV cases, we never expected to remove the oil. So we were putting in 5000. But now for CMB retinitis, I'm injecting 1300 and removing the oil also because they tend to do well. With acute retinal necrosis, sometimes I would tend to put 5000 because I want less emulsification because of the inflammation. And with our automated extrusion systems, it's no longer so painful as it used to be.
Yes, madam. Thank you, madam.
Yeah.
Ma'am, good morning. Shudipto here, ma'am.
Yeah, Sudipto, hi.
Ma'am, because a lot of patients have this compromised renal conditions, sometimes it becomes difficult to continue antivirals. So, those patients, do you inject intravitreal antivirals?
Actually, injecting intravitreal antivirals in the presence of silicone oil is a little dicey. But if the patient is post-renal transplant, then we also have the nephrologist in the loop. So I would leave it to them to decide how they want to handle the patient. Because this requires a lot of systemic coordination, and probably I don't think I'm the best person to decide. But yes, it is our responsibility to detect signs of reactivation and also development of ARN in the fellow eye, which is something I think cannot be underemphasized. Because we are so often concentrating on the eye that we've operated that we tend not to look at the other eye. This is one condition where before sending the patient back, you would like to do a dilated fundus examination. And check that everything is fine and don't stop the antivirals because we tend to think, yes, surgery is over, everything's fine. Sometimes it needs to be continued for almost 6 months, also to prevent optic neuropathy, which can.
Okay. Thank you.
Any more questions? I have a question, ma'am.
Yes.
So, should we for how many days?
Sorry.
For how many days should we continue with the antiviral, oral antiviral, even after the surgery? What
I
should
think I get my uvea colleague in the loop usually at this stage, but most of my patients have had antivirals for at least 6 months post-surgery.
from the beginning to 6 months or after the surgery?
Following surgery. Following surgery. And of course, if it's CMV due to post-renal transplant, then the nephrologist is in the loop. And if they have HIV, we have the AIDS center here where they would also take care. So we would just be monitoring the condition, the ocular condition. And once oil is inside, no intravitreals.
Thank you, ma'am. So if there are no more questions, then can we go forward with the next presentation? Thank you, ma'am. Thank you so much.
Thank you. Thank you so much for inviting me.
So the next speaker for this session is Dr. Anuradha Chandra ma'am. Ma'am has done her MBBS from Medical College Kolkata, followed by MS Ophthalmology with a gold medal from RIO Kolkata. She did her senior residency from RP Center, AIMS, New Delhi in glaucoma, strabismus and neuro-ophthalmology. She has also been awarded with FICO. She was the HOD of Pediatric Ophthalmology and Strabismus at Shushruth Eye Foundation and Research Center. Presently, she is working as Director, Global Eye Hospital, Kolkata. Ma'am was also a chief pediatric surgeon in the OphthaEva's project from 2013 to 2019. And she's the associate editor of Journal of OSWB, and she has various publications to her credit. Please write them down.
Thank you, Swati, and thank you, Sangeeta, for this lovely invitation. And thank you, Surabhi, for that lovely introduction. So I will be talking about something different, traumatic optic neuropathy. We already know that there are three mechanisms in which you can have direct injury to the optic nerve or indirect injury to the optic nerve. One is compression due to the edema or the hematoma, which is most commonly in the indirect TON, and transection can be direct or direct shearing force. So here we have a picture where you can see that there has been a direct trauma in the medial canthus, and initially the fundus doesn't show any picture, although the RAPD will be present, and 6 weeks later, once the scar has formed, there is a optic atrophy. So TON can be two types. What we are seeing here is a direct optic nerve avulsion. All these pictures are from the internet. So case one. So most common scenario which we can come across is a person coming to emergency with a 34 years sudden diminution of vision following a RTA. Because he was unconscious after the RTA and admitted in ICU, he didn't realize that he couldn't see with one eye. And once he recovered, then he gets to know that he has less vision in one eye. It can be anything from 618 to no PL. So on examination, if after 6 weeks the patient comes to you, you will find a optic disc pallor. So RAPD will be present. Most of the other findings will be normal, and you will find that there will be a optic disc pallor. So what are the investigations you are going to do? Definitely you will do a visual field. Visual field of this eye may not be possible, but obviously do the visual field of the other eye, because many a times there may be a field defect in the other eye as well, which will be missed. VP has to be done because it will be a documentation which is required, because each of these cases are medical legal cases, and you can do a color vision as well if possible. OCT will show you a loss of nerve fiber layer in all quadrants. So the diagnosis will be traumatic optic neuropathy indirect type. The main thing is documentation and counseling of these patients. After 6 weeks of like trauma, there is no role of steroids in these patients, but rehabilitation and counseling should be done with sympathetic hand. So case 2, RTA few hours ago, progressive pain and loss of vision with huge swelling of lids. When you see, it will be a proptosed tight eyeball with severe chemosis and restriction of the eyeball movement. Lids will be tightly shut. It will be very hard to open them up. There will be hematoma in the lids and the conjunctiva. Vision and pupils will be difficult to assess. Again, this is a picture from other internet from Vilsai Hospital. But what it is showing is that the scan done at that moment was showing a retrobulbar hematoma along with the right optic nerve sheath hematoma. So in this case, maybe a neurosurgeon opinion and opening up of the sheath can give vision to this patient. So the thing is, having a retrobulbar hematoma, increasing the orbital pressure and compressive optic neuropathy. In that case, a lateral canthotomy is going to save the eye. So it is an emergency. You need to get the internist and your oculoplasty surgeon if possible, and then you should go for a lateral canthotomy, because that is going to save the eye. Case 3 would be a 24-year-old man with a cricket bat injury to the nose and multiple facial fractures, multiple surgeries done, ICU admitted, and an ophthalmic opinion was sorted. And on a 3D CT scan, you could see a direct bone fragment impinging on the optic nerve. So in this patient, you have to see the RAPD, you have to see the vision. If it is no PL, very unlikely optic nerve surgery is going to help him. But if there is some vision, then maybe doing a surgical thing would be nice. Getting a neurosurgery opinion is important, because all these surgeries are now done endoscopically. This is another picture, another scenario in which you can see some optic canal thinning in the right eye when you are comparing it with the left eye, and there are multiple fractures also. So in these cases, again, if you want to intervene, you have to take a informed consent, because very likely the vision is not going to come, but still you can try. So what are the current strategies? Current strategies are systemic steroid therapy, optic nerve decompression, and a combined therapy of steroid and optic nerve. There are 2 other drugs which have come in, which we will talk about later. So whenever we talk of the trials, which was the most important trial, was the International Optic Nerve Trauma Study, which was the first study which was trying to randomize these trials. So what they did is they kept some patients untreated, some patients were on IV steroids, and some underwent a optic canal decompression. The problem with the study was it was very difficult to randomize, and after 2 years it was converted to a observational study because of the recruitment failure. And what the study said is that there is no significant difference in visual outcome after in all the 3 treatment groups. So after this, there was a crash trial and a NACS trial. The NACS trial said that you give steroids and the patient would do good. But the crash trial showed that mega doses of steroids was actually increasing the mortality of the patient. Why is it important? Because optic nerve injury patients often come with a brain injury patients. And if you are giving a very high dose steroids, you are likely to increase the mortality of this patient. So if there is a concomitant brain injury, please think and then give steroids. So what are the prognostic factors? So visual acuity at presentation is the most important prognostic factor. If it is nopial, very unlikely he will have some vision. So loss of consciousness, again, it is the severity of the injury that has happened. So loss of consciousness is considered to be a risk factor for gaining vision. Absent VEP, definitely that means the optic nerve has been transected. No visual recovery after 48 hours. This will also give you an idea that this patient is not going to recover. And a direct TON. If you have a direct transection of the optic nerve or optic nerve avulsion, it's not going to improve. So the role of steroids, this is the only thing we have in hand, is how to give it and what is the time, how do you start it, and what is the duration, what is the mode of administration. So the problem with steroids is that mega dosing, which was 2 gram and has significant morbidities which can be caused. So right now what the studies are showing is that you give a optic neuritis study type of treatment, that is 1 gram IV. If you can start within 6 hours, it's wonderful. If you can start within 48 hours, it is very good. After 1 week, it has very limited role, but it can be decided on individual case-to-case basis. The importance is to document each and every finding that you have about the patient. Duration, the normal optic neuritis study is 3 days or 5 days. You can, and then it is tapering dose of oral steroids, but only oral steroids are not going to help. So erythropoietin is another trial which has come in. It was done in 2011. Then there is a second study which has come in 2018. And what they are saying is that erythropoietin increases the ocular blood flow and it shows some improvement in the color vision. But when you see the significance, there is not much significance between the untreated steroid and steroid erythropoietin group. So that is one thing which can be taken care if you have a multi-center hospital. And other is the levodopa carbidopa, which has been again tried with 400 milligram of levodopa given along with the steroids, and it has shown some improvement. Again, it is not a significant improvement. So the take-home message would be there was no study which proved that optic canal decompression and steroids are better for TON. So the role of steroid has to be decided on case-to-case basis. If you have a worse visual acuity, likely the patient is not going to gain vision. And polytrauma is always linked. So if you have a brain injury, please send the patient to for appropriate management. And documentation should be done meticulously because each of these cases are medical legal cases. These are my references. Thank you.
Thank you, ma'am. So any questions from the audience?
Nice presentation. It's just that I want to emphasize certain things. First is prevention is better than cure. So like they should go out to all the people that to wear a simple helmet while riding a motorcycle would go in a long way in preventing traumatic optic neuropathy. And that requires coordination between the ophthalmologist, the treating trauma specialist, as well as the general people of importance in the government or in other sectors to make absolutely mandatory, in which they are trying. But people should also be aware of the thing. Second is the window period is 6 hours, if I'm made to believe. Now, most of the time, people who have traumatic optic neuropathy have polytraumas and they have huge lid swelling, so you are unable to access. And the place where they are, you cannot do any ophthalmic examination most of the time. So it would be better if, I don't know how it is done, if a mobile VP is possible or not, where the patient himself might not be conscious. So this coordination is to be done and that has to be taken care by the trauma specialist. And generally they come and later in and most of the time you cannot do anything. And another good point, madam, you have taken up is that to do the field test, irrespective of what is the vision in the other eye, because many a times we have seen some other ricochet effect or some other trauma that the person might be having. Patient might be a very old patient with a CVA. He might have fallen down a polytrauma case and he might have a stroke in the brain. We might miss on that, and which can be discovered later on. The other thing is that when an MRI is advised, the trauma person can also advise MRI of the orbit.
Yes.
So that most of the time is missing. So this should go out to all the practitioners, trauma specialists,
Yes.
So that prevention at the earliest stage can be possible.
Yes, that's true.
A nice presentation. Manmurtha, can you, in a nutshell, tell that what are the conditions where actually we can give IV steroids in these patients?
So
Maybe
you have
if you have a patient in your OPD,
you have a patient who has come to you early, maybe one day before he had a RTA which was not very significant, not a brain injury, no loss of consciousness, and the vision is 618, and the next day you see it's 624, you have a RAPD which is telling you that there is a optic nerve injury. In those cases, I think you should give a IV steroid, but right now it is 1 gram IV.
Okay, so no 2 milligram per day.
No, I don't think so. It's recommended right now.
Any contraindication to oral steroid in a traumatic patient? Like in ONTT trial, they say don't give oral Vicilon. But in a traumatic,
If you see all the literature, nowhere is oral steroids written. It is the IV steroid and a
Yes.
mega dose. Actually, the mega dose should be 2 gram. So, but there has been a lot of comorbidities with it. So, you are in a clinic where you don't have a
IV.
internist who is helping you out. So, 1 gram IV you can give safely, I think.
okay, so you don't recommend like if a peripheral ophthalmologist is there, so you don't recommend him or her to start a oral steroid in a trauma case, or
I cannot recommend it because it's not written.
not written, yes. But if that's the only option, then that's the
If
only
that's
option.
the only option, if he has nothing in hand,
Yes,
then maybe
something
that
is
would
better
be
than
better
nothing.
than giving nothing.
Thank you.
So, sir, any comments from you, sir?
Everything is covered. So there is nothing to add, I think so. So already she has covered everything. I don't think so. Anything has to be added.
Thank you, sir.
Okay.
So we'll go ahead with the next presenter.
So the next presenter for the session is Dr. Tripti Kontia, ma'am. She'll be presenting on approach to a case of posterior uveitis. Ma'am has done her MBBS from Kasturba Medical College, Manipal, followed by DA Ophthalmology from Kasturba Medical College, Mangalore. She did a fellowship in medical retina and uvea from SN Chennai. She was a consultant uvea and medical retina at Shroff Eye Center, New Delhi, and presently she is working as consultant uvea and medical retina at BBI Foundation and Netralayam, Kolkata.
Good morning, everyone. And thank you, Dr. Swati and Dr. Sangeeta for giving me an opportunity to speak on this platform. The topic is very, very vast, so I'll be just brushing upon the important points. So as the name goes, the primary site of inflammation in posterior uveitis is retina and choroid, which can include choroiditis, chorioretinitis, retinochoroiditis. That is when the inflammation goes from the choroid to the retina or vice versa. Solely retinitis, neuroretinitis, that is the inflammation of the optic nerve head, and vasculitis, that is inflammation of the blood vessels, retinal blood vessels. Could be etiologically divided into infectious or non-infectious, which is a very practical classification because the treatment depends a lot on this. Usually a sight-threatening condition and mainly a clinical diagnosis, and ancillary investigations and laboratory tests help in confirming the diagnosis. So patient will usually present with a complaint of diminution of vision, which will be incidence and onset, could be uni or bilateral. If we are thinking on the lines of posterior uveitis, then certain history becomes very important. For example, a recent travel to an endemic area or a history of exposure to pets, especially in cases of toxoplasma, and diet history again, if patient is having polluted municipal water or uncooked meat, which is again indicative of toxo. So when we are doing a clinical examination, the first and foremost thing we have to decide is whether the inflammation is retinitis, neuroretinitis, and so on. Also to look for associated vitritis or anterior inflammation, whether there is a granuloma. As I already mentioned, it can be divided etiologically into infectious and non-infectious. The broad categories include toxoplasma, toxocara, tuberculosis, Bartonella, viral, and HIV related. The non-infectious forms of posterior uveitis are usually grouped as white dot syndromes. Coming to ancillary investigations, these do help a lot in diagnosis. For example, color fundus photographs, we usually do these, we keep the pictures to follow up the cases and see whether the lesions are resolving over time. Fundus fluorescein angiography, very important tool in non-infectious uveitis, posterior uveitis, especially in choroiditis, where they have characteristic features. ICG mainly useful for deeper choroidal lesions like inflammatory CNV, etc. OCT, as we all know, to look for macular edema, ERM, macular holes, etc. Ultrasound again, important in media haze in cases of cataract or dense vitritis. Also important in cases of posterior scleritis and BKH, where choroidal thickening is measured. And there could be a normal fundus picture, but USG will reveal a thickening of the choroid and hence giving a clue. USG is also comes in handy tool when we have to differentiate tuberculomas with primary and secondary neoplasms in the choroid. And laboratory tests, we tailor it according to our preliminary diagnosis. PCR is again an important tool in cases of diagnostic dilemmas, where we can, if the DNA, if the genome can be detected in aqueous samples, then definitely it's considered positive. And last but not the least, thorough systemic examination by an internist to rule out systemic associations and manifestations. So broad treatment algorithm in posterior uveitis, this is mainly for infectious uveitis. We usually identify the characteristic or typical fundus picture, confirm with investigations, to treat the primary cause with appropriate anti-infective agents, systemic steroids, and additional anti-inflammatory therapy. Usually avoid periocular and intravitreal steroids in infective forms. And in diagnostic dilemmas, intraocular fluid evaluation for antibodies or PCR for identification of genome. Just a few infectious posterior uveitis. Ocular toxoplasmosis, mostly in congenital, it is asymptomatic punched out macular cicatricial lesion with a central necrotic zone involving retina, choroid, and vitreous. We can have almost 10% of patients presenting only with ocular manifestations without systemic association. But satellite lesions are usually formed at the border of old scars. Ocular toxoplasmosis happens to be the most common infective cause of posterior uveitis in immunocompetent patients, and the prevalence is higher in tropical areas. As I already mentioned, there could be a positive history of exposure to pets. Unilateral cases are present almost in 70 to 83% of cases. The cysts, they get activated in or near the retina and present as a focal necrotizing retinitis. Strong predilection for macular region, but peripheral retinochoroidal scars will be found in almost 82% cases if we do a thorough examination. As we all know, it is classically described as a headlight in the fog appearance, yellowish, white or gray exudative lesion with ill-defined borders. There could be a vascular involvement close to the lesion. Some uncommon presentations are neuroretinitis, vasculitis, and serous macular detachments. There has been evidence of parasite being found in the AC in immunocompromised patients. Usually antibody detection is not confirmatory by ELISA because the IgM peaks at 1 week and comes down in another 3 to 4 weeks, but IgG once becomes positive, remains positive for life. So we cannot really confirm the diagnosis on ELISA, but PCR is definitely a good tool. Coming to the treatment, it involves usually the destruction of cysts and prevention of recurrence. Pyrimethamine goes 100 mg first day, then 75, 50, and 25, along with sulfadiazine, and along with systemic steroids and folic acid supplementations. For patients who have sulfa allergy, azithromycin and clindamycin works best. Tubercular posterior uveitis, very, very important. When the eye is the primary site of initial site of entry, it's called primary, which is not that common. The most common form of tubercular uveitis is hematogenous spread to the eye, and that is seen in most of the cases. There could be hypersensitivity reaction causing retinal vasculitis also. The most common presentation is disseminated choroiditis. The tubercles, choroidal tubercles can also be present, varying from many to few. They are usually well circumscribed yellow, gray, white lesions, varying in size and elevation on the same picture. Also presents as choroidal mass ranging up to 4 millimeter in diameter, typically elevated with an overlying serous retinal detachment. Most of the times there is an underlying subretinal abscess. TB can also present as serpiginous-like choroiditis, intermediate uveitis, neuroretinitis, and vasculitis. If we do an fundus fluorescein angiography, it reveals activity in choroiditis. In subretinal abscess, we can see a classical ring of fire appearance. And in cases of retinal vasculitis, we'll see neovascularization and CNP areas. So investigations and treatment, most of us know. So it's hemogram and MAN2 with TB quantiferon gold test. Histopathological or microbiological confirmation from intraocular specimen is diagnostic. ELISA and PCR on serum are again not useful in endemic countries. Once the diagnosis is confirmed, we start anti-TB treatment and 4 to 6 weeks of oral steroids to avoid delayed type hypersensitivity. Viral retinitis, ma'am has already spoken a lot about it, but I'll just brush up again. The main culprits are herpes simplex, varicella zoster, and cytomegalovirus. Herpetic eye disease happens to be the most common form of infectious uveitis, and the clinical presentation depends a lot on the immune status of the patient. Herpetic posterior uveitis can be associated with systemic manifestations or isolated. And as ma'am has already told, it usually ends up in retinal detachment. A very important point here is if you have a history of chicken pox or associated manifestations of chickenpox, it could be a good diagnostic clue. Herpes simplex presents as acute retinal necrosis, dense vitritis, arthritis, periphlebitis, and confluent peripheral retinal necrosis. PORN presents as the difference between the two is in ARN the lesions usually spread from the periphery to the center, whereas in PORN it progresses outwards. And vitritis is very less in PORN. There is very minimal vitritis. And in early stages of PORN, the vessels are spread, giving a classical cracked mud appearance. CMV retinitis gives a classical pizza pie appearance with a lot of superficial hemorrhages and a brush fire pattern of spread along the blood vessels. So, also CMV retinitis presents as a frosted branch angiitis. So we start with antivirals such as acyclovir and valacyclovir in herpetic infections. This prevents infection in the fellow eye in the first year by almost 30 to 70%. Intravenous acyclovir is started 500 milligrams 8-hourly for 1 to 2 weeks for induction, followed by 800 milligrams 5 times a day orally. Alternately, valacyclovir is given, which has a very good bioavailability, that is 1 gram TDS. Low dose systemic steroids are usually required. As ma'am already mentioned, renal function monitoring is extremely important. In CMV, we use ganciclovir, intravenous 5 to 7 milligram per kg per day in 2 divided doses for induction, and then oral daily maintenances. Again, valganciclovir can be given, which has a better bioavailability in 900 milligram BD dose. Intravitreal ganciclovir or foscarnet has also been used in patients with systemic or renal dysfunctions. Coming to non-infectious, there are many other infectious posterior uveitis, but I just brushed upon the important ones. The others being syphilis, Bartonella, and Toxocara. Non-infectious posterior uveitis are grouped as white dot syndromes, and they have the names are basically on the characteristic clinical feature. First and foremost, we have to rule out infective causes. The mainstay of therapy is systemic steroids in non-infectious posterior uveitis. Usually, for vision-threatening lesions, we start with intravenous methylprednisolone and immunosuppressives in cases of non-responsive or recurrences. And the side effects of therapy needs to be monitored. Few of the white dots, as I already mentioned, named according to clinical appearance. FFA and ICG are virtually diagnostic. Lab tests are mainly required only to monitor the side effects of therapy. Patients usually complains of blurring of vision with photopsias, floaters, photomatas, and metamorphosias. APMPP is one of the WDS. Sudden loss of vision, appearance of these yellow-white flat lesions lying deep in the sensory retina. New lesions can appear till up to 3 weeks. Disc edema is an additional feature. Angiography shows early hypofluorescence and late hyperfluorescence. It has a self-limiting course with spontaneous recovery, and prognosis is usually very good. GHPC or serpiginous choroiditis, it's a rare bilateral chronic progressive recurrent disease involving RPE, choroid, and choriocapillaries. Gray-white lesions at the level of RPE. Usually active lesions are formed at the border of inactive lesions spreading outwards, and macular involvement is common. Multiple evanescent white dot syndrome, rare condition characterized by white lesions at RPE layer. This has a very characteristic FFA, which shows early patchy punctate hyperfluorescence with late deep staining of RPE and peripapillary area. These are classified as dots and spots. Usually patients present with a viral, almost 50% of patients present with viral-like prodrome and unilateral. Recovery is within 3 to 9 weeks, and which is excellent, and no scarring. The only only visual prognosis can be a blind spot enlargement. Coming to treatment, I've already mentioned in vision-threatening cases, we give IVMP 1 gram for 3 days, followed by oral steroids 1 to 1.5 milligram per kg body weight in the tapering form. Intravitreal steroids for refractory CME and unilateral cases, immunosuppressives with systemic monitoring. Inflammatory CNVM can be treated with intravitreal steroids or anti-VEGF. Last but not the least, masquerade, some non-uveitic conditions that mimic posterior uveitis, especially neoplasms. Lymphomas and secondary malignancies can present as viral retinitis. Possibilities of leukemias and retinoblastomas in children. Choroidal melanoma and secondary metastasis can mimic choroidal abscess. USG is a very important tool in diagnostic dilemma. And AIDS-related posterior uveitis like HIV retinopathy and cryptococcus infections. So to conclude, a diagnosis of posterior uveitis is mainly clinical, essential to differentiate between infective and non-infective because the treatment is diametrically opposite. Empirical use of systemic steroids and immunosuppressives to be completely avoided. Intraocular fluid for PCR and antibody testing in diagnostic dilemma. It's very essential to follow up patients even after resolution of lesions because they tend to develop secondary complications like retinal detachments, inflammatory CNVM, etc. If the optic disc and macular involvement is present, then they can cause irreversible vision loss and hence the need of early diagnosis and appropriate management. Thank you.
Thank you, ma'am. Any questions from the panel? From the audience?
Excellent presentation. What we were discussing was it's actually a challenge to complete the whole of posterior uveitis within so short a time, but you had done a very commendable job. Congratulations for that. I don't have much of questions. I have a few comments especially for the audience and especially for the youngsters who are sitting here. The first of which is, in all cases of anterior uveitis in your clinic, do not leave the patient from your clinic before you have dilated and seen the fundus, because it can so happen that anterior uveitis is just a spillover of whatever that's happening behind. So always, unless and until you have done a thorough IO in a dilated fundus, do not leave the patient giving steroids. The second point, which I think is very important, is sometimes we have a tendency, especially when we have a busy OPD, we have a tendency to, when we see that there's a posterior, there's a posterior uveitis, we have a tendency to give oral steroids and ask the patient to go and come back after a few days. Do not do that until you are very sure that you are not dealing with an infective uveitis. Once infective uveitis, at least the usual culprits have been ruled out, then and only then you start steroids. And of course, how to taper the steroids, when to taper the steroids, that is a whole chapter again. But once you have given the steroids, if you have autofluorescence, that will help you to determine when you are when we will try to taper the steroids. Any other comments from other panelists? Yes.
Actually, just wanted to discuss one confusing patient of mine. There was a male patient. I diagnosed that as toxoplasma retinochoroiditis. I gave acid, Septran, and Visalon. Responded. The presenting vision was 6/60, became 6/6. Okay, and the patient was very happy. Came back to me after 3 months. Similar lesion. This time I started the same therapy. I thought maybe it's a recurrence. This time it did not respond. We had got the VDRL done the first time itself. It was positive, but the titer they said was not significant. Second time also, after 3 months, I got the VDRL repeated. It was positive. Then I was confused whether it's syphilis, because syphilis I have hardly seen. Like my post-graduation days, I have seen 2 patients, but right now it's not there. So I was very confused. So then I sent it to a medicine guy. They got the OphthaEva's done. OphthaEva's was negative. So the guy said, although I'm not making a diagnosis of syphilis, he did start on antibiotics which covered the organism, and surprisingly this time it responded. So is it what's the take, what's your opinion, like, to diagnose syphilis in these days? Like, is it possible to be OphthaEva's negative and VDRL positive? Should I consider it to be syphilis, or should I leave it to the medical doctor to decide? Because that's one patient, like I have not seen syphilis since last 5-6 years. He has no other symptoms or anything. I've asked till the level I could ask him in my OPD, because I cannot ask too many questions in my OPD because there are too many patients around. So should we consider just VDRL positive as a
very difficult situation? I must agree with you. Usually what I do in my practices, I don't give VDRL only, VDRL and TPHA.
TPHA.
Yeah.
Sorry,
I give
TPHA,
it,
yes, sir.
together, right? VDRL and TPHA. And if I find that both are positive, then the patient needs antisyphilitic treatment.
Okay.
But yes, when VDRL is negative, I mean, VDRL is positive and
the specific test is negative.
Yeah, OphthaEva's is negative, then it's definitely it's a very difficult situation. But if you are seeing that the patient is deteriorating, the situation is deteriorating, it might go out of hand, then probably it would be rational to start with antibiotics also.
Because I concluded finally the first time the patient responded was because of the azithromycin, because azithromycin does cover
Probably,
some.
yes.
So that was my final diagnosis,
Yes.
and I thought my clinical judgment was wrong in the first place, but finally we got it right for that patient. So definitely, if I see a VDRL positive, then treat it if it's not responding. Okay.
Yeah, and the other thing is whenever you are suspecting, I mean, you're giving the uveitis workup, you can give 2 together.
Yes, yes.
VDRL and TPHA.
Yeah.
So you
that
have
will be better,
both
I
of
feel.
them together instead of just giving
Just
VDRL.
VDRL, yes.
Yeah.
Thank you.
So very nice presentation. I just want to emphasize on one thing, is that many a times we see an OCT and we see cystoid macular edema, and immediately we ask for Ozurdex or anti-VEGF injection. So I would ask you, from your uveitis perspective, what else you want to see apart from the anterior segment and the vitreous cells before asking for injections, one, and second is what in an apparent normal eye of the other eye, what you tend to see, which can show that it is more of an uveitic etiology?
We look for pars plana exudates or snowballs if it is an intermediate uveitis. And usually if it is an intermediate uveitis, also we must at least exclude TB before advising an intravitreal steroid. And if there's nothing on the retina, if the retina is clean and you have ruled out TB, then I think you can safely advise an intravitreal steroid and make sure there's basically the main important thing is to look for snowballs in the pars plana.
Yeah, if I may add upon it, I mean, you are bang on target when you are saying this. If you can't indent, if you indent, when you are doing a IU here, if you can't indent, get hold of somebody who can indent and see the pars plana. But without seeing the pars plana, you shouldn't start steroids.
I think we can go.
Thank you.
Very good presentation. You have summed up nicely, and most important thing, to see the patient as a whole. You have to take, starting from history, you have to see all the things. Posterior uveitis, you have to see anterior, intermediate and posterior, all the segments. If there is any involvement in the, as you said, if you see the anterior involvement, you must see the posterior also. So everything has to be covered. All the history is very important. As he said, that some VDRL cases also that has to be venereal case. Disease also have some problems also. So this is very important in uveitis management. And also you have to take the pan fundus photograph. It is very, very important. The all the fundus area, periphery has to be photographed and documented. That is important. So very nice presentation. Thank you very much.
So the next speaker for the evening is Dr. Richa Kamal ma'am, who will be talking about chronic CSCR and its management. Ma'am has done her DNB ophthalmology from Rotary Narayana, Kolkata, followed by comprehensive ophthalmology fellowship at SN Kolkata. She has also done a VR surgery fellowship from Priyamda Birla Arvind Eye Hospital, and she is presently working as consultant at BBI Foundation, Kolkata, and Narayana Super Specialty Hospital, Havra. Please, sir.
But first of all, good morning to my seniors and my colleagues. First of all, I would like to thank Sangeeta ma'am and Swati ma'am for giving me this opportunity. My topic for discussion is chronic CSCR, what to do. So as we all know that chronic CSCR comes under a pachychoroid spectrum, which is characterized by serous detachment of neurosensory retina at macula and pigmentary changes. Chronic we say if there is persistent SRF for at least 3 to 4 months. So either it could be because of diffuse RP decompensation or because of altered choroidal permeability with changes in choroidal vascularity leading to thickened choroid. So how do we differentiate with acute CSCR? First is duration is very important. Acute is usually self-limited, and chronic or recurrent, they can persist for more than 6th or 7th decade with atrophic or neovascular sequelae. There, in case of chronic CSCR, there is diffuse abnormality of RPE, unlike acute, and there is leading to persistent SRF. There is shallow serous retinal detachment, low to flat PED, and there on autofluorescence, we could see gravitational tract or RPE tract sign, which is actually depigmentation or secondary decompensation of the inferior RPE, which on AF photo we can see as hypo autofluorescent bordered with hyper autofluorescent. So any pachychoroid disorders, they have basically 3 tomographic features. First is increased choroidal thickness, then dilatation of the outer choroidal vessels, which is pachy vessels, and attenuation and thinning of the overlying choriocapillaries and the middle choroidal vessels. So if we see on EDI OCT especially, there will be thickening of the deeper and thinning of the overlying inner choroidal layers.
thinning of the posterior surface of the detached retina with hyperreflective detached photoreceptor tips that will give a brush border appearance, and thinning of the outer retinal layers. If we do OPTA, and if it is only chronic CSR, there will be dark area seen corresponding to the SRD. And if it has gone for any neovascularization, we can actually see the neovascular fronts over there. So FFA, numerous leak points in early phase that increase in leakage in late phase, and RP window defects and RP tracks hyperfluorescence we can see. ICGA is very important. We can see the dilated choroidal vessels, and with some focal hypocyanosin pinpoints that shows the non-perfusion of choriocapillaries. So if it is chronic CSR only, we can do focal laser, and if it is extrafoveal, that allows the pump function of surrounding healthy epithelium to return fluid to CC. And there is a Nevila system which performs precise targeted treatment. Then PDT, that is photodynamic therapy with verteporfin, which is not done much nowadays. It is actually applied to areas of choroidal vascular permeability. Here the verteporfin accumulates in the abnormal vessels, and there we give red laser that converts oxygen into oxygen-free radicals, and that damages the locally the endothelium, causing blockage of the abnormal vessels, induces as absorption of SRF and choroidal vascular remodeling. We can the disadvantage is increased VEGF and CNV, and so we can use half dose or half fluence. Others include subthreshold micropulse laser, which works on the principle of thermal elevation of retina that releases heat shock proteins leading to repair of RP cells, or TTT, that is transpupillary thermotherapy, or sublethal thermal effect. So there is oral, also we can use oral mineralocorticoid receptor antagonist that works on the principle that usually mineralocorticoid receptors are present in the endothelial cells of the choroid. So glucocorticoids, they bind to it and induces calcium-gated potassium channel that releases, that causes hyperpolarization leading to vasorelaxation, leading to increased permeability. So these eplerenone, they act as competitive antagonist of these mineralocorticoid receptors and thus modulates the local permeability. However, the contraindication is pregnancy, severe heart, liver or renal failure, hyperkalemia. Concurrent use of AC inhibitors or ARBs and NSAIDs or lithium. And there are several studies on it. One of them states that there is comparable favorable anatomical outcomes with subthreshold micropulse yellow laser and eplerenone, but visual outcomes were not significant, probably because of the chronicity of the pathology. So this is a chart given in Ryan for treating management algorithm of CSR that states if it is in case of CSR, chronic CSR, if it is extrafoveal, we can either give focal laser or half dose PDT, and if it is subfoveal, we can give PDT and also oral treatment. Okay, so dealing with other pachychoroid spectrum diseases, that includes pachychoroid pigment epithelium. Here there will be focal juxtafoveal RP changes overlying areas of dilated choroidal vessels, and on OCT we can see pachy vessels with CC compression overlying with overlying RP disruption. PCV, we can see polyps on ICG and corresponding OCT tall peaked PEDs. Pachychoroid neovascularization, if we do OPTA, we can see the presence of neovascular fronts, and on OCT pachychoroid vessels with presence of pachy vessels and CC compression, shallow PD with SRF that shows the active lesion, and here comes the role of anti-VEGF. Then, so PP and CSR, they appear in early 30s or 40s, and with over time, they can convert into pachychoroid neovasculopathy, which in some eyes may develop into PCV. So other DDs we have to rule out, like optic disc pit or AMD or inflammatory infectious disease like VKH or posterior scleritis, autoimmune and vascular disorders, or intraocular tumors. So my take home message is, though observation is the standard initial management in most cases of acute or classic CSR, active treatment should be initiated when symptoms persist for more than 3 months, and proper investigation of chronic CSR being a pachychoroid spectrum is very important. So if at all required, we can intervene. Thank you. Any questions? So we'll move on to the next speaker for the session, Dr. Kalpita Das, ma'am. Ma'am will be speaking about classification-based approach to retinoblastoma. Ma'am has done her MBBS from Calcutta National Medical College, MS Ophthalmology from PGI Chandigarh, followed by, she was also awarded DNB, clinical fellowship in VR and ocular oncology. Ma'am has done from SN Chennai.
and she's associate consultant at VR and Ocular Oncology Services at SN.
Good morning, everyone. And thank you, Dr. Sangeeta, for this opportunity. And I am going to discuss here, discuss about a little serious topic. I am here to discuss about a little bit more serious topic, that is retinoblastoma. Serious because this is a fatal malignancy in very small kids, usually less than 5 years of age. And however, it's very satisfying to see them in the OPD when they come with their parents with all smiling faces when they complete treatment, because they are mostly cured and perform in various activities in the school. And older kids, they follow a very normal life with very good professions. So my topic is that classification based approach to retinoblastoma. So as the treatment of the retinoblastoma has evolved through the era, so we need to brush through the history a little bit about the retinoblastoma. That the first description of retinoblastoma came in 15th century by Peter Powers, and Heinz first described the term of leukocoria, in that's like a cat's eye in the dark. However, the first description of retinoblastoma as a clinical entity came from James Wardrop in 1809, and he was the first to perform enucleation for retinoblastoma also. This was the drawing of by James Wardrop, how beautifully he depicted retinoblastoma and extraocular retinoblastoma in that era. And Verhoff in 1922 they coined the term retinoblastoma, and the term was adopted by American Academy of Ophthalmology in 1926. Retinoblastoma is a genetic tumor, so it is the prototype of genetic cancer. RB1 gene was the first tumor suppressor gene to be identified in the medical history, and Knudsen's two-hit hypothesis was given for retinoblastoma, which says that a second sporadic mutation should occur in patients with hereditary retinoblastoma before development of the tumor. So coming to the treatment history, the first treatment modality which was available for retinoblastoma was the enucleation, and James Wardrop was the first person to do an enucleation for the retinoblastoma. And von Graffe told that a long piece of optic nerve should be obtained during enucleation to prevent spread of the tumor to the CNS. Then comes the role of radiation for the treatment of retinoblastoma. The first use of radiation was in 1903, and the landmark Rees-Elsworth classification, which was based on external beam radiotherapy, came in 1963. And chemotherapy, which is the standard of care now, has been in action since early 2000. So Rees-Elsworth classification came in the era of EBRT. So this classification was mainly based on the size, location, and the number of tumors. However, this classification, which came in the era of external beam radiation therapy, helped for prognostication of the eye salvage, but not the systemic prognosis. And in this classification system, peripheral tumors were more difficult to treat. That's why they are staged in a higher classification. With time, we have seen a lot of adverse effects related to external beam radiation, like severe optic orbital hypoplasia, retinal toxicity, and particularly many-fold increase in the secondary malignancies in heritable retinoblastoma. Therefore, this classification is obsolete now. Then comes the era of chemotherapy. So with the chemotherapy advent of treatment, we understand the goal of treatment of retinoblastoma primarily to save the life of the child. And when we are sure of the saving of life, then we can plan for globe salvage and finally the vision salvage. So the clinical indications in the era of chemotherapy is an extraocular retinoblastoma, where it's used to prevent the spread of the tumor along the optic nerve, and chemoprophylaxis for patients with high risk of retinoblastoma, that is called adjuvant chemotherapy, where following enucleation, we find a positive cut-end of the optic nerve or high-risk features on histopathology. Then comes the indication of chemo reduction with adjuvant local therapy to increase the likelihood of globe salvage and vision preservation. And bilateral cases of retinoblastoma. So the most important indication is now is a chemo reduction with a chemotherapy. So for the chemo reduction, we have to classify the retinoblastoma. The major classification is the intraocular retinoblastoma and extraocular and metastatic. So we do a tumor staging for survival and tumor grouping for eye salvage. So tumor staging system comes when the eye is enucleated and we stage the patient, whether the patient, how is the chances of survival. For intraocular retinoblastoma, the classification comes in 2003. There were two classifications given at the same time by two groups. The first, the classification which is followed in most of the places, that is International Classification of Retinoblastoma, ICRB, where the tumor is grouped into 5 groups, A, B, C, D, and E. So A is the tumor where it's a very, so A is the tumor where we can see it's a very small tumor around less than 3 millimeter, which is situated away from the main structures of the eye, that is the optic nerve and the macula. Group B, when the tumor is located close to the optic nerve and the macula. This is also group B. Whatever the size of the lesion, if it is situated close to the optic nerve and macula, will come to the group B. This is a large tumor involving the macula, and we can see tiny peripheral seeds along the tumor. So this falls into the group C. So when there is a surrounding SRF and we can see tiny vitreous seeds around the tumor, this is also group C. This is a diffuse tumor with a diffuse seeding all around the retina. So this falls to the group D. And where the tumor has destroyed the most of the structures of the eye, this falls into the category of group E. So another atypical variant of retinoblastoma will be the diffuse infiltrative retinoblastoma, where the retinal leaflet and thickened and the tumor has involved more horizontally the retinal leaflets. So another classification of retinoblastoma by AJCC cancer staging system. Why this system is important? Because this is the only TNM system in this classification group which describes the heritable trait of retinoblastoma. So coming to the management of retinoblastoma is individualized approach. But this is based on several considerations like age and presentation, laterality, tumor group and staging, visual prognosis, systemic condition, and economic consideration. So the mainstay of diagnosis of retinoblastoma will be a good indirect ophthalmoscopy and aided by ultrasonography and imaging like MRI or CT scan. So when a child comes to the OPD, need a brief history in the OPD and need to rule out the simulating lesions. Ultrasonography in typical cases shows calcification. MRI rules out any extraocular extension and optic nerve invasion or any intracranial extension. Metastatic workup is needed for orbital or metastasis disease and followed by a thorough examination under anesthesia in the OR. Coming to the treatment protocols, so if the retinoblastoma is unilateral, the group A tumors, those are very small tumors, can be treated with focal therapy alone, that is in the form of TTT or cryotherapy. Tumors from group B, C, and D needs chemo reduction with systemic chemotherapy with focal consideration. Group C and D, along with it, will need the management of the seeds. And group E, in most of the cases, needs enucleation. And the chemotherapy regimen for most of these retinoblastoma cases used are vincristine, etoposide, and carboplatin. So when we're dealing with a patient with a bilateral retinoblastoma, we need to look into both the eyes. So if the tumors involve bilateral small both eyes with small extrafoveal tumors can be treated with focal therapy alone. But when the disease is asymmetric and the worst eye is up to maximum group D, so we treat these patients with systemic chemotherapy and each eye as outlined for the unilateral disease. And when in asymmetric disease, the worst eye is group E, the worst eye needs enucleation along with systemic chemotherapy and the better eye treated as said earlier. And in cases of bilateral advanced disease, the child is treated with primarily the systemic chemotherapy. And the new player in the field is the intra-arterial chemotherapy. In this cases. So intra-arterial chemotherapy, which is also known as ophthalmic artery chemosurgery, is a unique method of targeted chemotherapeutic drug delivery to the affected eye by an intra-arterial catheter, where by fluoroscopic guidance, the ostium of the ophthalmic artery of the affected eye is super-selectively catheterized by a microcatheter. And the most commonly used drugs are melphalan and topotecan. The advantage of this particular method is lower systemic side effects and concentrated chemotherapy doses. However, the disadvantage is that this technique is technically challenging, and the cost issue, particularly in our country, limits the use of ISE. So ISE is mostly used as a primary treatment for unilateral or biretinal retinoblastoma through group B and in most of the cases, it's used as a secondary treatment following failure from other treatments. So if we seen the outcome of ISA versus IVC for A, B, and C group, the outcome is almost the same, where it plays a major advantage in group D, where we can see the from 47% to 94%, the eyes can be salvaged with IAC. So another treatment modality which is available for retinoblastoma is intravitreal chemotherapy, where the principle is to achieve the maximum drug concentration to the tumor with maximum therapeutic doses with lowest systemic concentration. However, the treatment modality is never used as a primary treatment modality, and it is used only in cases of persistent and recurrent visits following the systemic therapy. So there are few of the cases representation, like this was a patient of unilateral group C who was treated with intravitreal chemotherapy with focal consolidation with TTT. So this is the outcome. We can see a small calcium chunk sitting in the center. So another girl, 1-year-old girl who came with a one eye group D and other eye was group A tumor. So this kid was going through the systemic chemotherapy. So after 3 cycles, we can see there's a significant reduction in the tumor size. This was following 6 cycles, and this is the 18-month follow-up. We can see that the tumor has mostly scarred, even though a small remnant is still sitting on the center, which is still undergoing chemotherapy, TTT. And there was another tumor in the periphery, which has completely regressed following systemic therapy. And at the same time, the other eye small tumor was treated with cryotherapy and completely regressed. Another 2-year-old girl with bilateral retinoblastoma, right eye had group E, where the tumor has completely involved the eye. The left eye was group C, had multiple peripheral tumors, one in the nasal side, one in the superior side. So following 6 cycles of intravitreal chemotherapy and focal therapy, the left eye tumor has completely regressed. The right eye had to undergo enucleation. So this was a 1-month-old male child, was a unilateral group E. However, because the eye was ophthalmic, I plan to go ahead with systemic chemotherapy. And surprisingly, after 1 cycle of chemotherapy, we have seen that the tumor has significantly reduced. We have started seeing the optic disc, the peripheral retina, the exudative RD. So this was following 1 cycle of chemotherapy. The tumor, we can see the significantly reduction after 3 cycles, and after 6 cycles, we can see a large calcium chunk sitting in the center with a retinal fold and the peripheral retina attached with a healthy retina. So the child still had some peripheral vision. So this was another child who had bilateral advanced disease. Right eye had group E and left eye was group D. Right eye had to undergo enucleation. This child underwent a IAC, that is intraarterial chemotherapy in the left eye, and following 3 cycles of IAC, there was a complete regression of the tumor. This was another child, 1-year-old, unilateral group D, primary ISC. Following 5 cycles of ISC, there was complete regression of the tumor. So evolution of treatment of retinoblastoma, we see whether in 90s, it was more than around 98% mortality. From 19th century to 1950s, the primary treatment was enucleation, followed by EBRT. In 1990s, it was IVC. From 2010, it has now moved to ISC and intravitreal chemotherapy. And with that treatment, now we can achieve more than 98% survival for these kids. However, these statistics fits in the Western world, because from 95% mortality over 50 years ago, now we have achieved 98% survival because of early diagnosis and improved methods of treatment. However, in our part of the world, we still see advanced disease because there is a barrier to care. They reach to us very late. There's delayed detection of the tumors, and when they present, they all become high-risk cases. So therefore, to conclude, retinoblastoma is a potentially curable malignancy of childhood if detected and treated on time. Standard classification-based treatment protocol has been established to maximize the possibility of glove and vision salvage without compromising on life survival. There is a paradigm shift in treatment from radiation to IVC and now to intraarterial and intravitreal chemotherapy. An individual management plan is required to lead optimal outcome. So World Retinoblastoma Week is celebrated every year in second week of May. These are some of my happy kids who has completed treatment. And thank you.
Excellent presentation.
Thank you so much, ma'am, for the wonderful presentation. Any questions from
Just,
the panel?
I want to add one thing. When I just, if you find a case of high FEMA, then you must also exclude retinoblastoma.
Any small children which comes with an unexplained vitreous hemorrhage or high FEMA or hypopyon or red eye, we should always rule out retinoblastoma in them.
And every child, every baby has to be seen both eyes, fundus examination at the earliest moment. So that is very important. Then you can exclude retinoblastoma in early stage and can treat with lasers. So these focal lasers can improve. That this is a very
any cause of unexplained vision loss, anything unexplained but has no, even sometimes the history of trauma may be coincidental in them. So we need to rule out retinoblastoma in all those cases.
Thank you.
Thank you.
Thank you so much, ma'am. So introducing our next speaker, Dr. Sneha Batra. She has done her fellowship in cataract, refractive surgery and medical retina at BBI Foundation, Kolkata. She has various awards to her credit. She has multiple publications in IGO. She's also a reviewer for Clinical Ophthalmology Journal. And she has been a moderator for various AIOS sessions. Dr. Sneha will be talking about management of recalcitrant CNVM.
So good afternoon, everyone. Lovely to come down from a very rainy Siliguri to a very warm and sunny Kolkata for a wonderful meet today. I must thank Swati ma'am and Sangeeta ma'am for having me here. So I'm going to talk about a topic. When this topic was given to me, I myself was a little confused. But when I went through the literature, I think this is something that we all face in our practice, but do not like to talk about in the conferences because we usually show our victories and not our defeats. So anti-VEGF molecules are our magic drugs. You see a patient with CNVM and macular edema, and you immediately tell your patient 3 injections, maybe multiple injections may be required. This is your course. But what are the other things that you tell your patient? Do you tell your patient that there are a lot of other things which are involved in the treatment? There are the expectations of the patient and what we are expecting, the morphological outcome, functional outcome, they are not always what we think about right at the start. So I'm going to start with this figure. This is the CAT study where ranibizumab and bevacizumab was studied. And it said that despite monthly treatment, and that is not something that we are doing, of course, monthly treatment for 2 years, 51% of patients who were treated with ranibizumab and 67% who were treated with bevacizumab still had some persistent fluid on OCT. And when we see the aflibercept treatments, even in this case, 19 to 36% patients had some amount of fluid after a period of 1 year. So what to do now? Next, what is the efficacy of your treatment? So when you're starting your treatment, is this something that we discuss with our patients? What are the chances that this molecule is going to work in our eye? So going through all the literature, it is seen that the efficacy rate of bevacizumab is 59 to 68%, 61 to 75% for ranibizumab, and 79 to 83% for aflibercept. I'm not talking about brolucizumab here. The data is still in its very initial phases. So there are 20 to 40% of patients who might not respond to the molecule that you are choosing for them. Now, when you go through the literature, there are a number of terms, very confusing, all starting with R's: resistant, refractory, recalcitrant. And when we are, analyzing the treatment, what do we write on the prescription? What has happened to the patient and what are we going to do next? So this is one of the best studies that I could see, and this classifies the response according to morphology and functional outcome. Both of them are very, very important. And again, the response has been categorized according to chronology. So you can categorize it: primary response, that is the 4th month, just 1 month after your 3rd monthly injection. Then there is the secondary response, which is any time between month 4 to 11. And there is the late response, which occurs after 12 months. So you can again categorize the response as morphological, which you can go through the chart. In the interest of time, I'm not going through it entirely. How much the SRF and the IRF has reduced, and the functional outcome in terms of visual acuity gain. Now, it is important to know that when the patient's visual acuity has been good from the starting, that means the functional outcome may not increase as per the chart. So that is something which is called as a ceiling effect. In that case, you look at the morphology maybe. So the same study had defined failure. This is not the definition that we are using at present, but I'll just go through it. Primary failure was seen 1 month following the 3rd initiation dose, and the secondary failure was which had responded initially, but later on went on not to respond so effectively. So now, who do we call a failure? So when we are saying that someone who has not responded to 3 treatments are failure, and the patient has taken 3 injections, are you going to ask that patient to take more of the same molecule when no change has occurred? The answer is yes. So this is something that has been seen in the Marina and Anchor trial as well, that as many as 30% patients, and that's a very sizable number, the response is seen after 4 months of treatment. So now the protocol that we follow is that at least 6 months you should be following up with the same molecule before thinking that this medicine is not working for this particular patient. So recalcitrant, that was the topic that we are talking about, is now defined as persistence of IRF or SRF after 30 days of the 6th injection, as opposed to tachyphylaxis, where the patient had responded initially and now is no longer responding to that molecule. So there are a number of risk factors. I'll just run through these slides in the interest of time. The patient's baseline visual acuity is one of the most important things. So that is what determines which patient will respond and who will not. Chronicity, someone who is responding to treatments, but gradually with time, the disease becomes more and more chronic, and there can be progression of the associated disease, whether it is ARMD or myopia or any other disease. Before we call a disease recalcitrant, rule out that your diagnosis is not correct or the dosing and follow-up has not been ideal. Why this happens? Because it has been seen that some patients have a different biological picture, and VEGF may not be the only criminal factor here. There are a number of other pro-angiogenic factors also which are now coming up in research. So this is the chart again. Just to summarize, see the morphology as well as the visual acuity. If the response is good on both accounts, continue with your treatment. If morphological response is good and not the visual acuity, rule out other diseases. Maybe there is a progressing cataract or a glaucoma or any other disease. If both are not responding very well, that is the time you think of changing your treatment. What can you do? Again, what merits a retreatment if your disease is becoming more active, which can be in the form of presence of SRF, a new hemorrhage, or any BCVA loss which is attributable to a disease of the lesion activity. You need to treat more. What to do in these cases? The only thing that we do at present, there are a number of other strategies which have been researched but have not been found to be fruitful. This is the only treatment which has been found to be fruitful, is to switch. Now you switch to which molecule? Usually aflibercept and brolucizumab, because they have been seen to have a different kind of a chemical composition acting on a different pathway. So there have been a number of studies both on aflibercept and on brolucizumab, which say that patients who had not responded very well to bevacizumab or ranibizumab, these have been now found to have some response when these molecules are used. Other strategies which are there in the literature but we don't use very often: PDT, not very available. Reducing the frequency of dosage was tried, but it has not been approved. Steroids were tried by some authors, but again, the response had been short-lived. And there are a number of other molecules for which research is going on, but again, they are not available right now. So this is just summarizing whatever I have said till now. Now, just that one question that I'd like to leave everyone with: after everything that you have done, when do you stop treatment? We all know when to start treatment, but my question is, when do you stop a treatment? So this was one of our patients, 85-year-old lady. One eye had been lost to exudative RD due to CNVM. The other eye had received 15 injections, was improving till some point, but over the last 3 injections, there was no improvement in the visual acuity. So there is a lot of scarring, subfoveal. There were some end stage biomarkers like ORT, which was developing, and the patient is not responding. So again, this is something that I asked the panel: what is your criteria to stop treatment? Repeated injections with no improvement in visual acuity, scarring, end stage biomarkers. What are you thinking of now? So this patient, we offered to switch to aflibercept, and despite no visual change in the no change in the morphology, the visual acuity did improve, and she could be maintained with 2 to 3 monthly injections of IGAN. So I'd just like to conclude by saying that the 7UP study showed us that anti-VEGF therapy is sometimes a very long and arduous process. It's a journey which the patient embarks with you. And you have to realize that sometimes the visual acuity will go down despite all the treatment that we do. But then it is a journey that you have to try, and the patient needs to keep trying with you. Thank you very much.
Thank you, Dr. Sneha. Panelist members, any questions?
In case of scarring, why do you continue treatment? Last you say, why you have treat with aflibercept? It's no use, I think so.
Yes, sir. So we have seen in some particular cases where we had the same question that you asked, there is a lot of scarring. Will the visual acuity improve or not? But as I said, the response sometimes is it is not connected, the morphological and the visual acuity response. Some people, the visual acuity improves despite the morphology not showing a very good change, and vice versa can also take place. So as long as one outcome is taking place, especially the visual acuity improvement is taking place, you can try for it.
Sir, another thing is that the difference is that when a person comes to you, he comes for vision. But when we treat it, we treat the disease. So a balance is required. At certain point, we need to say that, okay, it is not working and we might stop. But sometimes in PCV, newer lesions can crop up at the side of the old scarred lesion where you need to treat even though the vision might not improve. Sometimes this bleeding might cause vitreous hemorrhage and even cause choroidal hemorrhages. And so sometimes treatment is necessary. The patient should fully know that it's not going to benefit him in vision whatsoever. The only problem is that when we inject, we tell the patient, "Apnar choke drishti bhalo hoye jabe." So that should not be. We should say, okay, this is to treat the disease. Now, generally, when in private practice or even in certain practices, we tend not to, because generally they improve a lot. But the only thing we should say to the patient, which we should not, is that we are only delaying the inevitable.
Very important thing what Rimalo has mentioned, that probably the counseling to the patient is very important, that it's actually a 5. I usually tell patients that it's actually a 5 to 7 years disease. And whatever drugs we have in our hand are to maintain the vision, but we get a significant improvement if we start treating the patients very early. So probably these 3 points are very important if you start treating AMD, especially apart from these myopic CNVMs and inflammatory CNVM.
Even though even the OCT is bad, though the patient is having good vision, that can also happen. So we don't treat the OCT, we treat the patient and the disease itself. And the ORT is a significant point where we can stop, and the no improvement of 3 consecutive injection there, that point we can stop or switch to some other anti-VEGF. If the patient is just not responding to that also, then we can stop treating the patient. If the patient must be having degenerative cyst and ORT, then we have to go for FFA to see whether there is any leakage or not. And see the OCT also. The size is remaining the same for 3 consecutive injections. Then no point in treating those patients.
I would corroborate with Krishnendu that if there are consecutive 3 injections where there has been no noted improvement, then it is the time to call for us change the injection, or otherwise say that no, this is not going to improve any further. Having said that, what I would like also to answer Dr. Biswas's question, like there are some OCT biomarkers which have been classically mentioned that they are supposed to have a poorer prognosis. One of the examples being SHREM. Now, if we all, I mean, say for the last so many years that we had been treating AMD, we had seen that if there's presence of SHREM, it would signify that it might have a worse prognosis. Now, very strangely, with the newer molecules, it has been observed by several observers, several clinicians, that with the newer molecules, in spite of SHREM, there is an improvement of vision. Now, that is quite surprising. We had never seen that with the older molecules before.
Shomin, I think that there are 2 classifications of stream now. We have vascular and vascular stream.
Right.
Because the vascular streams are having response.
Yeah, that's exactly what I was going to say. In the newer molecules are actually addressing the vascular SHREMs better than the older molecules. So it's not just the SHREM, the presence of SHREM that would determine, it would also what to determine is what kind of SHREM it is and whether it would respond to treatment. So just seeing a SHREM doesn't mean that you have to stop treatment.
Also, the total area of scotoma matters to some of the patients. Like some of my patients are like 636, 660. They are not going beyond that, but the fluid is recurring. But what they complain is sometimes that the boundary of the scotoma, they can see when the injection is there. When the injection is not there, the scotoma is more. So it's up to the patient also to decide. And I feel teaching them how to use the Amsler grid also teaches them there is some improvement after injection, increases compliance also. So this scotoma is somehow not addressed by any of our parameters in our treatment. So that probably if can be mapped out in some way for those old patients, as in the chronic patients. And most of these patients are one eye. That the other eye is a PCV scar of finger counting, and you're treating the other eye which is 636. Should I stop treating? It depends on the patient, and also my opinion also matters. But if the scotoma is improving, I feel, and the patient says, "Ki doctor, wo bhalo lagche injection e pore," I would want to keep treating that patient. If the patient is affording, obviously, has a insurance, or if it's not an insured patient, obviously you can go for the cheaper alternatives as well. We're not taking into account the visual quality of light index. So that part probably is more important.
Very true. Very true.
Thank you, Sneha. I think very nicely put slides. Thank you.
Thank you, Dr. Sneha. The next speaker for today is Dr. Sangeeta Roy, ma'am. She'll be presenting a potpourri of cases of posterior segment trauma. Ma'am has done her MD ophthalmology and senior residency from RP Center, AIMS. She was also awarded the fellowship of ICO in 2014. She was initially the VR consultant at Girival Eye Institute, Chandigarh, and Shushrutai Foundation, where she was also the HOD of teaching and training. Currently, she is the director and consultant at Global Eye Hospital, Kolkata. Thank you.
So I'll be just presenting a potpourri of some trauma cases.
Years-old boy presenting with a history of firecracker injury 3 months back. The patient presented with corneal opacity, a self-absorbed lens matter, and vitreous hemorrhage. After clearing the remnants of the lens, vitrectomy was done. Then a localized retinal incarceration was seen in the supratemporal quadrant along the supratemporal arcade. ERM peeling was done around it. Followed by a air fluid exchange, and silicone oil was injected.
Thank you.
Any comments from the panelists? So we'll move on to the next speaker for today, Dr. Romana Fazil, who will be talking about current updates on vein occlusion. Dr. Romana Fazil has done her MBBS from Calcutta National Medical College and Hospital, DNB from Arvind Eye Hospital in Pondicherry, fellowship in surgical VR from Arvind Eye Hospital, Pondicherry, and she's presently working as VR consultant at Shushruth Eye Foundation, Berhampur.
So good afternoon, everyone. I want to thank Dr. Sangeeta Madam and Dr. Swati Ma'am for giving me this opportunity. So this is a very vast topic, but I'll try to make it concise. So retinal vein occlusions, these are the second most common retinal vascular pathology after diabetic retinopathy. Macular edema is the commonest cause of vision loss due to RVO. BRVO accounts for 80% of all RVOs. And CRVO can be ischemic or non-ischemic. Diagnosis is mainly clinical. OCT is used for monitoring purposes, and OCT angiography wherever available is preferred over FFA to detect macular ischemia. So starting with CRVO, non-ischemic CRVO may resolve completely without any complications. 30% of non-ischemic CRVOs may convert to ischemic variety over 3 years. Follow-up of such cases for at least 18 months is recommended, and when we see development of disc collaterals and spontaneous resolution of macular edema for at least 6 months, it indicates a good outcome. Ischemic CRVO, 90% have final visual acuity less than 6/60, and up to 60% of ischemic CRVO may develop neovascular glaucoma. So macular edema in CRVO, so anti-VEGF injections are the mainstay of treatment at present. Ranibizumab and aflibercept are the FDA approved agents. These drugs have been studied in Cruz, Galileo, and Copernicus trials, which are the landmark trials. In these trials, monthly injections for 6 months was followed by PRN dosing till 12 months compared to sham group. And there was 15-letter gain seen with anti-VEGF agents in more than 60% of patients. So these patients were further followed up for another 12 months in the Horizon RVO and Copernicus study with aflibercept. And in the second year, patients were monitored every 3 months. And the worsening of outcomes was seen in the second year with this elongated follow-up. So at present, the concerns are to maintain the visual acuity and the edema resolution for a long period of time. So for that, how many injections are required?
Many studies have advocated 6-monthly loading dose. Some studies have advocated 3-monthly loading dose. What treatment regimen to follow, how to keep the duration of follow-ups, monthly, PRN, treat and extend. And of course, there is a cost burden also. So other alternatives are there, Avastin, which is off-label, or biosimilars, which are have very good outcomes seen. And so after the results of Horizon study, the Crystal study was done to to evaluate an individualized stabilization criteria driven regimen. In this was a 24-month study duration, prospective study. Loading dose of 3 injections was given, 0.5 mg ranibizumab, followed by PRN. But the follow-ups were kept monthly for the first year. Then in the second year, if the vision had stabilized and there was no activity, then the follow-ups were gradually increased to 2 months maximum. So the results were stable visual acuity was achieved in 37% after 3 monthly injections, and 14.3% after 4 monthly injections, 6.4% after 5 monthly, and 9.2% after 6 monthly injections. So mean number of injections over 2 years, 13.1, letter gains were 12.1. And in this study, macular ischemia duration was not found to affect the results. And duration of if the CRVO had been less than 3 months, they had better outcomes. So just over a third of patients will require only 3 injections to reach the maximum visual acuity, while another third will require 6 injections. This was another study in which 7 monthly ranibizumab injections were given, and then after that 2 arms were there, PRN dosing for another till 15 months, and another group for monthly ranibizumab injections till 15 months. So in this, they concluded that edema resolution was very good with PRN dosing also, but follow-up was done monthly. So this is a treat and extend protocol studied with aflibercept for 18 months. Here 20 patients were enrolled. 3 monthly loading dose was given, and treat and extend to maximum of 12 weeks was seen. And in almost 70% of these patients, it was possible to increase the interval between injections by an average of 2 weeks. Score 2 study. This is a comparison between bevacizumab and aflibercept having similar visual acuity outcomes in patients with macular edema with central and hemiretinal vein occlusion. So 65% of eyes in the aflibercept group had a 15-letter gain at month 6 versus 61% in the bevacizumab group. So comparison between a monthly and treat and extend protocol in patients who had a good response after 6 monthly injections of aflibercept in the SCORE 2 trial revealed no significant difference in vision gains in the arms at 12 months, but significantly less injections in the treat and extend arm. LEVO study, this concluded that this was a study between ranibizumab, aflibercept and bevacizumab. They concluded that ranibizumab was not inferior to aflibercept, but bevacizumab in terms of visual acuity gain at 24 months showed an inferior outcome, but this was a post hoc analysis, so it was not very conclusive. So macular edema and neovascularization in ischemic CRVO, many clinical trials tend to exclude patients with very poor visual acuity. So eyes with presenting vision of 696 or worse, anti-VEGF should still be considered if there is presence of significant edema, as reasonable improvements may still occur. But however, if the edema has resolved with no improvement in visual acuity following the trial of anti-VEGF, then cessation is recommended after 3 injections. And after cessation of anti-VEGF, 1 to 2 monthly observation for neovascularization is recommended. And anti-VEGF therapy has to be commenced when there is earliest sign of iris or angle nevus cells. This was a trial RAVE trial for studying the incidence of neovascularization after cessation of anti-VEGF. So monthly intravitreal ranibizumab treatment was given for 9 months. After that, monthly monitoring for 3 months was done, observation, and then monthly examination with PRN treatment on evidence of disease activity for 24 months. They found that out of 20 patients, 9 patients developed neovascular complications during the 24-month follow-up period, and with 2 patients developing neovascularization after completion of the 36-month trial endpoint. So continued follow-up is required even especially during the first year, and also after that, after cessation of the anti-VEGF therapy. Intravitreal steroids are used as explained in the was studied in the Geneva and SCORE trials. Geneva used 0.7 mg Ozurdex versus sham, and SCORE used 1 mg triamcinolone versus 4 mg triamcinolone, and compared with laser or observation. So both of them, the steroid arm had better visual gains, and 1 mg was better, had a better safety profile. So role of PRP was studied in decreasing the number of injections, RELATE and WAVE trial, but there was no significant benefit found. So in BRVO, the landmark trials were Bravo and Vibrant. Bravo for ranibizumab and Vibrant for aflibercept. In Bravo, 0.3 and 0.5 mg ranibizumab were given monthly, followed by PRN till 12 months, and they were found 61% found a 15-letter gain versus 29% in the sham group. And similarly to the aflibercept, at 6 months, 53% subjects gained 15 letters after mean of 5.7 aflibercept injections. So these are in short Horizon trial, which was an extension of the Bravo, and it compared the long-term safety of PRN ranibizumab till 24 months. In contrast to the CRVO patients, the BRVO patients still vision was stable till 24 months even after prolonged follow-up. And Brighter trial compared ranibizumab with ranibizumab plus laser versus only laser. There was no additional benefit of laser found. The Retain study was follow-up still 4 years. They found that 50% patients had edema resolved after 2 years of injections, and they had better visual acuity gain. And some unresolved cases, 50%, they needed injections even in the 3rd and 4th year, and they had lesser visual acuity gain. Marvel study was between ranibizumab versus bevacizumab, and Comrade B was 3 monthly ranibizumab followed by PRN till 6 months versus a single dose Ozurdex. So ranibizumab showed better gain. This is a recent trial. This is a recent trial, randomized Zipangu trial, which is they have tried 1+ PRN regimen for ranibizumab in treatment naive patients, and mean number of ranibizumab injections between monotherapy versus combination therapy with laser. Duration of the study is 12 months, and better outcomes were seen even in the 1+ PRN ranibizumab strategy. That may be due to shorter duration of RVO. So newer treatments are broclusizumab, but it has not been recommended for RVO because of side effects, and suprachoroidal injection of triamcinolone with aflibercept in the Tanzanite study has been seen, and about a large proportion of patients have been followed up till 3 months, and they have not required retreatments. So summary, anti-VEGF is the first line of treatment for macular edema in CRVO and BRVO. To maintain the good anatomical and functional outcomes, follow-ups should be at least monthly intervals initially till vision is stabilized for at least 3 consecutive visits. Treat and extend is a good regimen to reduce follow-up visits and still maintain good outcomes. 1+ PRN regimen can also be followed, but especially if the duration of RVO is short. In poor response to anti-VEGF, switching to alternative agent from ranibizumab to aflibercept or steroids can be done. And CRVO patients should be followed up after cessation of anti-VEGF to detect neovascularization early, especially in the first year? Thank you.
Dr. Romana. Inviting the next speaker for today, Dr. Asmita Saha, who will be speaking about OCT biomarkers in diabetic macular edema. Dr. Asmita Saha has done her fellowship in surgical retina and uvea from Priyamda Birla Arvind Eye Hospital, and she has done her senior residency from Nair Hospital, Mumbai. She is presently attached with Disha Eye Hospital since the last 3 years.
Good afternoon to all. I'll be speaking on the topic OCT biomarkers in DAB. Thanks for giving me the opportunity. So first we need to know the layers from inner to out of the retina to understand the biomarkers. Is the internal limiting membrane, the nerve fiber layer, the ganglion cell layer, the inner plexiform, the inner nuclear layer, the outer plexiform layer, outer nuclear layer, the external limiting membrane, the ISOS junction, the RP, and the choroid. So is it easy to pick up these biomarkers? Do these biomarkers influence the management of DME, and are they useful for prognostication? So in order to know, we have to see the markers of function. They predict the visual acuity gain in eyes with baseline diabetic macular edema. So these are the external limiting membrane disruption, the loss of ISOS layer, the parallelism, and the ellipsoid zone hyperreflectivity. These are the markers for predicting the visual acuity gain. The markers for predicting the response to anti-VEGF steroid and vitrectomy are the central macular thickness, the retinal process, the intraretinal cyst, the hard exudates with shadowing, the hyperreflective dots, the neurosensory detachment, and the epiretinal membrane with wrinkling. So as we can see in this photograph, there are large cysts with eversion at the fovea and presence of the hyperreflective dots, and there is neurosensory detachment with the external loss of the ISOS and the external limiting membrane. So the single parameter, the central macular thickness, is not a predictive indicator of visual acuity. We need to know all the biomarkers in order to know the visual acuity gain after an anti-VEGF therapy. So this is a 47-year-old man, diabetes for the last 4 years, controlled on oral hypoglycemic agents with hemoglobin HbA1c 7.1 and best corrected visual acuity of 6/6 partial. So as we know from the protocol V of the drcr.net, that more than 20/25, if the vision is good in center involving diabetic macular edema, then whether we observe or we do focal laser or aflibercept at 2 years period, 2/3 of the patient will maintain good visual acuity. So in this patient, we observe the patient, we ask for DM control, and after 6 months, the visual acuity improvement is 6/6. So there is mild focal intraretinal thickening with preservation of the vision to 6/6. This is 54-year-old lady with diabetic on oral hypoglycemic agent and hypothyroid with best corrected visual acuity of 6/12. As per the protocol A, we compared the OCT measured CRT and the visual acuity, and there is modest correlation between them after laser photocoagulation. So in this patient, we can see the parafoveal hard exudation, and in this case, when the visual acuity drops, we either follow the patient for 2 years, and if the visual acuity drops, we do focal laser. So we have done focal laser in this patient, and there is decrease in the vision. This is 3 months after treatment, and 6 months after treatment, there is resolution of the edema, central edema, with vision of 6/6. This is 56-year-old gentleman, diabetic hypertensive on oral hypoglycemic agent with best corrected visual acuity of 6/36. So there are presence of hard exudation, and there is retinal hemorrhage, and the foveal reflex was dull. So In this patient, the central macular thickness was 431 microns. So this is before treatment and after treatment with 3 doses of anti-VEGF. The CMT reduced to 229 micron with best corrected visual acuity to 6/9. So in this case, you can see there is some amount of disorganization of the inner retinal layers and loss of the external limiting membrane and the ISOS. So the vision improved to 6/9. So this is another patient with nephropathy, diabetic and hypertensive with HbA1c 8.9 with best corrected visual acuity of 6/60. So physician referral was done to control all systemic parameters, and there is an association of the neurosensory detachment with the systemic pathology. So in these cases, injection razumab was given and there was resolution of the edema. So similarly, this is one case where the visual acuity improved from 6/18 to 6/9. So OCT helps in monitoring the vision, where you can see the visual acuity from 6/12, it improved to 6/9. The central macular thickness from 303 to 269. So OCT helps in measurement, OCT helps in monitoring the prognosis. So although in this case, this is a patient with 6/36 vision with intraretinal edema, gross intraretinal edema, there was anatomical improvement, but the visual acuity gain was only 6/24 because of the disorganization of the inner retinal layers and the loss of the external, the ISOS junction and the external limiting membrane. So OCT also determines the mode of treatment. So this is a case you can see there is intraretinal fluid with there is a vitromacular traction with vitromacular adhesion with hyperreflective dots. So in this case, the mode of treatment is surgical. So there is interface disorders in these cases where it requires surgical intervention. This is another case with a lot of tractional CME with 1000 micrometers central macular thickness. This is 1 month after surgery and 3 months after surgery with resolution of the edema. So OCT helps in monitoring the prognosis in such cases. So this is another photograph where you can see no active intervention was done just because there were a lot of hard exudation which caused disruption of the external limiting membrane and the ISOS with gross thinning at the macula. So there was nothing to do in such cases. So we should know what is drill. Drill correlates to regions where bipolar, horizontal and amikrine cell synaptic connections have been disrupted. So drill affecting more than 50% of the central 1 millimeter zone has worse visual acuity in eyes with current or resolved edema. So here you can see these are the inner retinal layers. So these inner retinal layers, the white line depicting the ganglion cell layer, inner plexiform layer, inner nuclear layer, the yellow line depicting the inner nuclear layer and the outer nuclear layer, and the blue line, the outer plexiform and the outer nuclear layer. So there is a loss of, there is a disorganization of the inner retinal layers apart from the CST, which predicts the vision. So in DME, visual acuity change over time was best associated with drill change over time. Persistent drill after resolution of the DME was associated with a less favorable outcome. Another is the hyperreflective dots, which should be differentiated from the microaneurysms as microaneurysms and the hard exudates. Here you can see the hyperreflective dots. They can be present in all the 3 layers as you can see. So we know the microaneurysms are present in the inner retinal layer, superficial layer, nerve fiber layer, and the hard exudates are present in the outer plexiform layer. So these hyperreflective dots are less than 30 micrometer, less than the microaneurysm size. There is no back shadowing in these cases, and the reflectivity is same as the nerve fiber layer. So this is another photograph showing the taut posterior hyaloid with intraretinal cysts, and there are presence of hard exudates in the inner retina causing back shadowing. So fundus autofluorescence also play a role. So intravitreal steroid, as we can see from the Vivodex study, this play a very important role. See, this presence of hyperreflective dots with neurosensory detachment and a gross edema, there's a resolution of the edema with intravitreal steroid. So in these cases, we can think of giving steroids after instead of the anti-VEGF. So role of OCT biomarkers in DME. Hyperreflective dot shows highest value in inflammatory pathology and can guide treatment. Subfoveal hard exudates with shadowing are associated with good response to anti-VEGF and an important biomarkers. If we find neurosensory detachment, we can go ahead with the steroid treatment. Parallelism will correlate with the structural changes. This parallelism term is very important. So this is the binarism between the external limiting binarism image of the external limiting membrane, the ISOS and the RP. So if it is lost, then there is decrease in the vision. So DME with ISOS disruption and decreased parallelism warrants a guarded prognosis. Baseline residual central retinal processes. Within the large cysts, we have the retinal processes. So if these retinal processes are found, then these patients are going to have good vision improvement after anti-VEGF. Eyes with ERM involving the macular central with a gross vitreomacular traction, the visual prognosis will be less with anti-VEGF. So one more important thing is the macular ischemia. It is an important biomarker how we can monitor. We can monitor with an OCT angiography. So poor response to anti-VEGF, how we can see with small vessel density parafoveally. Then additional microaneurysms can be picked up on the OCT angiography and a wider FAS in the deep capillary plexus. As we know, the choriocapillaries are more in the deep capillary plexus, so it will define the prognosis after an OCT angiography, after an intravitreal injection. So to summarize, the OCT demonstrates microanatomy of the macula. It classifies the type of the diabetic macular edema. It guides in a proper treatment plan. It monitors the prognosis, and also it is a predictive biomarker of visual acuity. So a single parameter, the visual acuity may be very good with a very thick central macular thickness. Vice versa, a normal thickness can have a very less visual acuity. So a single parameters is not predictive. We should see all the biomarkers, including the hyperreflective dots, the presence of the disorganization of the inner retinal layers, and especially the ISOS and the external, the ISOS and the internal limiting membrane reflectivity to find out what will be the vision after an anti-VEGF. Thank you.
Thank you, Dr. Asmita. With this, we come to the last speaker of the session, Dr. Oindrala Das. She has done her MBBS from College of Medicine and JNM Hospital.
Very good
Kalyani.
presentation, Ashmita. Very good.
So Dr. Oindrala has done her MBBS from College of Medicine and JNM Hospital, MS from RIO Kolkata, and she is currently working as senior resident at RIO Kolkata.
Good afternoon, everyone. Thank you, OphthaEva, for giving me this opportunity to present here today. So I'll be presenting a case of retinal detachment, which presented with an intraoperative surprise. So this was a 74-year-old hypertensive male who presented to our OPD with complaint of sudden dimness of vision in the right eye since 2 weeks. On examination, visual acuity was hand movement close to face, and PR was accurate in the right eye. On fundus examination, we found an inferior retinal detachment involving macula, although the primary break could not be located. So the patient was posted for surgery. I'll be showing the video of the surgery. Although this case was not done by me, it was done by Dr. Sneha Jain, our senior resident, and I had assisted the case. So initially, core vitrectomy was done. After doing core vitrectomy, the vitreous shaving was done from over the area of retinal detachment, and there we located a hole inferotemporally. Here we can see the hole it was located, a small hole was located infratemporally. So we proceeded with the case. Vitrectomy was continued, and while shaving the vitreous from around the edges of the break, we noticed that this was the hole that we had located, and there was an outer retinal hole as well. Here, this was an outer retinal hole. So we diagnosed that this was not only a case of retinal detachment, it was actually a case of retinoschisis with progressive rhegmatogenous retinal detachment. So Oracort assisted vitrectomy was done. Then after completing vitrectomy, both the holes were marked with endolaser. Here we can prominently see, this was the inner retinal hole and this one was the outer retinal hole. So there was splitting of the retinal layers. Then vitreous base shaving was done and the periphery was checked for any other holes. After that, the inner retinal hole was enlarged so that both the holes were made overlapping and fluid air exchange was done. Then both the holes were lasered. After that, silicone oil was injected as tamponading agent. So the patient on post-op follow-up 3 weeks had a BCVA of 6/60 with plus 5.5 diopter spherical and silicone oil in C2. And we can see that the central retina was settled and here are the laser marks infratemporally. So this was done in a Ingenuity, that is heads up 3D visualization system, and that had a shared view that helped as a teaching tool for the residents, and they could be shown the 3D effect and the splitting of the layers, the outer hole and the inner retinal hole, and this was a great experience for both the surgeon and the assistant. So I am thankful to Dr. Sneha Jain for sharing this video and allowing me to present here. Thank you.
Very nice video. One thing is that could you not see there is a breaks and the beforehand, before doing the surgery,
No,
before
actually,
planning for the surgery?
Yeah, actually it was not examined by me or Snehadi. So whoever had examined and posted the patient could not locate the break. It was assumed to be the case of rhegmatogenous retinal detachment.
This is rhegmatogenous detachment. There is no doubt about it, but you should have detected earlier so that you can plan accordingly. But because of this beautiful 3D machine, you could solve the problem on the table. Okay.
I would like to invite Dr. P.N. Biswas sir to give the token of appreciation to our panelist members. Dr. Devmalya Das sir.
So we come to an end of the second session, and it had been really wonderful to have you all here. Dr. PNB sir.
Dr. Krishnendu Nandi sir. Dr. Saptarshi Majumdar sir. Dr. Somen Mondal sir. Dr. Sudipta Das sir. I would like to invite Dr. Mahua Sen Gupta ma'am to give the vote token of appreciation to our speakers. Dr. Tripti Kontia ma'am. Dr. Richa Kamal ma'am. Thank you, ma'am. Dr. Devmalya sir, can you please come? Dr. Devmalya sir will be presenting the token of appreciation to Dr. Kalpita Das ma'am. Dr. Kalpita Das ma'am. Dr. Sneha Batra. Next, I would like to call Dr. Krishnendu Nandi sir to present the token of appreciation to Dr. Dr. Sneha Batra. Dr. Saptarshi sir, please come forward to present the token of appreciation to Dr. Romana Fazal. Dr. Somen Mondal sir. Dr. Somen Mondal sir will be presenting the token of appreciation to Dr. Asmita Saha ma'am. Dr. Sudipta Das sir will be presenting the token of appreciation to Dr. Aindrila Das. Thank you, sir. I would like to invite Dr. Swati ma'am to present the token of appreciation to Dr. P.N. Biswas sir.
Please do honor our moderator for the session, Dr. Survi Ruya, who is an associate consultant at Shushrudaya Hospital and has done a great deal handling the entire program and coordinating it. Thanks, Survi. Before we go on for a photo session, I would like to invite Mr. Shailendra Sharma, who's flown all all from Mumbai to here from Ajanta Pharma, and to say a few words. We'll have a photo session after this. Mr. Sanjay Srivastav.
Good afternoon, everyone. My name is Sanjay Srivastav, based at head office Mumbai of Ajanta Pharma. On behalf of entire team of Ajanta Pharma from head office and entire team of Calcutta, we are extremely thankful, particularly OphthaEva's for giving this such a wonderful program opportunity for all of us to participate. Sir, as far as the Ajanta Pharma is concerned, in no new introduction, we are extremely happy to share 41 innovation brand has been launched by Ajanta Pharma first time in India. This is only possible because of all of you. All the time we are getting encouragement from all of your side, sir. And we are very happy to say that we have developed a very recent ultra modern dedicated plant at Guwahati, which has given a new feather in our cap as far as the manufacturing unit is concerned. We are extremely, just like I would like to highlight the innovation that recent introduction in antioxidant, that is OptiGold, which is a very, very thoughtful combination. Next, I would like to say that is Retigen, which is another new innovative formulation as far as the antioxidant formulation is concerned. Our flagship brands in antioxidant, that is Macogol Plus and Ocogol Plus. And recently we have introduced a very, very wonderful innovative formulation that is HypoClean, which is a eyelids and eyelid cleaner, which I am confident this will be quite useful in day-to-day practice. As far as the lubrication is concerned, we have recent innovation as far as the dry eye management is concerned, that is Ultimate, that is Maximize Ultra and Softwish Ultra, which is 0.3% sodium hyaluronate with trehalose. Of course, we have introduced in glaucoma management, that is ROCK inhibitor, that is Ripasudil as well as Netarsudil, which has really quite encouraging response we are getting, and it has definitely revolutionized as far as the glaucoma management is concerned in India in recent past, sir. What we are getting the feedback from most of you, not only in glaucoma, but also in cornea, as for the adjuvant therapy, as for the first line therapy also, it is giving wonderful response, Netalo as well as Dipatec. We are confident, doctor, this type of program will definitely help all of us to participate more and more, and your always togetherness, which help us to participate in future program also. We are extremely thankful once again to Chairperson, Dr. Abhijit Ghosh, this moderator, Dr. Swati Agrawal, and Dr. Sangeeta Rai, who has nicely organized this program and very live participation from even hybrid program also, and senior respected Dr. Ashish Bhattacharya sir, who has made this show a very live and interesting. Once again, thank you each one of you for giving this opportunity. Thank you so much.
Thank you so much, Mr. Srivastav. Ajanta Pharma has been with us from the days of inception of OphthaEva 5 years back in 2017, I must say, and since then OphthaEva has grown. I would request all the members who are coming here for the first time, all the females, to become members of it, and I would request all the males to please continue supporting us the way they have done before, and would expect your support and inspiration in the future also. And with this note, I would invite everyone to join us for a photo session. We'll just take a group photograph. Please, everyone. Thank you.